Okay, good morning, everybody. Dear Ruta, thank you so much for the kind introduction. And I'm very proud to be here. Thank you so for the invitation. And our CEO of our company and me, we are really impressed to see modern Vilnius. We are really impressed. It looks like Frankfurt. Not that high, but basically it looks like that. So for today, I will not show you how proper dentistry is to be. I'm deeply convinced that you are perfect dentists. But I would like, and this is how we impressed already Ruta in Munich, I would like to introduce you to a new terminology in dentistry, and this is called osteoimmunology. That means our main research is what is going on in jawbone. What is going on in jawbone when you extract a tooth? What is going on over years when you have done a wisdom tooth surgery? Or what is going on in jawbone when we insert an implant? And so the subtitle is The Smoldering Fire in the Jawbone. The chronic inflammation inside the jawbone. And it's not only of local interest. I would like to introduce you and to present you science-based data that these local inflammations might have an overall health impact. That means systemic, I would like to introduce you to systemic diseases and neglected inflammation in jawbone. And the main question at the end is, why is it me to come from Munich to Vilnius, to Lithuania, to talk with you about this osteoimmunology, about this chronic inflammation, about this smoldering fire in jawbone? Why is this subject neglected in mainstream dentistry? And the reason is probably up to now, beyond this ultrasonography, we have no proper means to detect these smoldering fire in the jawbone. So this is, in short terms, the schedule for this day until late afternoon. Now, I would like to introduce you our team in the clinic. These are my young colleagues, which are doing also the surgery. And this would be the schedule, but I think we don't go through all these items. Just to build up my credibility in you, you can have this paper here, over there, and you see here 4 QR codes. And these QR codes give you access to my up to now 23 PubMed indexed research papers. That means everything what I'm presenting you here is already published on a PubMed level. That means this is science. We can discuss it, okay, but nobody can say when you believe what Dr. Lechner is saying, this is pure rubbish. This is not true, okay? So I'm saying this because still many doctors say our subject about osteoimmunology in jawbone is not really existing, it's not important, okay? It has no consequence and no impact in daily practice. This is not true. Oh, okay. So, that's what it is. Now, a short introduction again. To show you where I came from 45 years ago. When I started dentistry, my interest already was the combination of dentistry and, let's say, naturopathic medicine. And this is here Professor Hans Selye. Professor Hans Selye was in the early 1930s. He got the Nobel Prize for what? For introducing the term of stress. He was the first one to define stress. And that means here stress is more or less the reaction of the body. It's an alarm situation. And the connection to my subject is chronic inflammation in jawbone might be a chronic alarm situation. So already nearly 100 years ago, a Swedish professor got the Nobel Prize for this aspect. Chronic inflammation is a chronic stress and is bringing our body into a chronic alarm situation. Chronic alarm, chronic alarm, chronic alarm. So to show you how a normal body is reacting on stress. Here we have the initial situation here, and now the stress is coming. So the body is getting a shock. Okay? You are extracting a patient's tooth. And this means all over the body is coming into a shock phase. And now, second is to overwhelm this shock. It's a hyperreaction. What is it? It's our swelling, it's our pain, okay? It's our hyperemia after the surgery. And then after a certain time, it goes back here to the level of a healthy situation, okay? This is a normal reaction. And a normal reaction keeps us healthy. It doesn't matter what it is. Is it a virus? Yeah? Is it a letter from the taxman or whatever it is? Okay? All these shocks can be compensated by our body. And in each second of our lives, we are reacting like this. The problem is, in case we have chronic strain, we get out of this normal reaction. And in case of a chronic alarm situation, our body or our adrenals, more or less, are exhausted. And when the body, through the chronic alarm situation, is exhausted, the normal reactions here are gone. We get a shock, and the patient remains inside the shock. And staying inside the shock means all normal compensations, compensatory reactions of the body. That means hyperemia, better immune supply, and so on, is blocked, is not reacting. And in case this goes on for years and years and years, here, this is the norm, shock, staying in the shock, and staying here in this area means the body will not react anymore properly. Properly to keep up its own, let's say, immunological, energetic, or physiological health. It's too far to explain all these reactions here, but this is very interesting, and we call it, and we focus on it, this is the regulatory system of the body. And basically, the question is, what here is our aim? Why are we taking out root fillings? Why are we taking out amalgam fillings? Yeah? And so on. Here. All these disturbance fields like amalgam or incompatible material or root fillings or jawbone cavitations are disturbance fields. And these disturbance fields might be traumatic, for instance. Yeah? When you had an accident, you get a trauma. And in case the trauma continues your alarm situation, yeah, it's a problem for your health. Yeah? And after 20, 30 years later, it might be the reason or the cause to get cancer. Yeah? So each disturbance field has a total body impact. Yeah? It might be also psychological. Yeah? My mother-in-law might be a psychological disturbance field for me, which is not true. She was a perfect cook. Just to give you examples, what are disturbance fields here? And, very important, a disturbance field endangers or limits the order or coherence, the inner coherence of a living system. This is very important. The better your inner coherence is, inner order, the healthier you are, the healthier you will stay in future. A very important aspect. Excuse me, all the ladies, for this little for this example. But the question is, why women live longer? That's just funny, okay? So here you see the driver of this car. Here. No, come on, here. For this driver of this car, this wonderful lady is a disturbance field, okay? This lady, to look at this lady, is disturbing its, is disturbing its inner order, its inner coherence. And this is the reason why it's crashing into this, is crashing. Okay, so this is more academic. Sorry, doesn't look so nice, but it's more academic. So these are all possible disturbance fields to damage or limit our inner coherence. Toxins, solvents, molds, biocides, plastics, metals, bacteria, everything brings us to a nitrosative stress, and so on and so on and so on. And this then all these, including mitochondria here, including oxidative stress, including chronic inflammation, including disturbed immune tolerance, all these things where doctors and medicine is working with each day on many, many patients. And in many, many cases, they fail because the connections are very, very complicated. Yeah? But at the end, our task just should be to enhance the inner order or the coherence, the inner coherence of a living system of our patients. So we just have to do two things in daily practice. We have to find out where is the chronic root cause to damage our system, to limit our inner regulation, our inner coherence. So suddenly medicine becomes pretty simple. It sounds like that. So this is all of this from a published paper from a nice doctor. I'm a professor in Regensburg in Germany. And this is basically the problem, because first here, we are a long time below the so-called symptom threshold, okay? And all our patients are just coming into the clinic when the symptomatic disease is coming up. But nobody is going to the doctor here in this here timeline, where the symptom threshold is below. So, and the chronic strain starts here and ends up here. And we are not talking today about acute infections, of course, yeah? Getting a virus, COVID-19 or whatever it is. Yeah? The problem is the chronic strain. Why? Because the chronic strain normally is hardly to detect. And it comes up only when this symptom threshold here is overwhelmed. And then we have all these symptoms and we have the disease activity. We call this in science here, this point is called start of maladaptation. Okay? Again back, the better the regulation is, the better is your possibility, the quality of your adaptation. In each second your body has to adopt to the coffee, you basically, which is basically not compatible for your digestive system for you. Yeah? But you're here anyway, because your body is able to adopt. In case your body would not be able to adopt, because you have a chronic strain, you have 10 root fillings, whatever it is, yeah? Then you would get out and have to go to the bathrooms because of the coffee. Yeah. So this is about the holistic background. I would like to introduce you a little. And okay, adaptation and so on. So there is a critical difference between typical inflammation and chronic inflammatory systemic diseases here, which separates the asymptomatic phase from the symptomatic phase of a chronic inflammatory systemic disease. This is the asymptomatic symptomatic threshold. This is the background. Just never really forget this background when we are talking about details, scientific details. Why is acupuncture valid, is working? Yeah, I did it a long time ago. And now the problem is it's all energetic. And to make visible the body's energy is very complicated. Okay? We have no X-rays for energy. We have no ultrasound device for energy. But we have a so-called Kirlian photography. This is not so interesting. Kirlian was a Russian doctor. And it's very simple. You keep your fingers and your toes in an electromagnetic field with a paper. And then a high tension field is making the picture of your energetic flow around the fingers and around the toes. Very simple. So here you have 10 fingers and 10 toes. Now, what is missing on this picture? This young lady has lost her toe. She has no right big toe. When I saw this picture, a lady was sitting in front of me, I said, oh my God, by which accident did you leave your right big toe? She said, my right big toe? The toe was there, yeah? No pain in the toe. But she had a scar here on the end of the big toe. And she was precisely remembering where this scar was coming from. She was cycling with naked feet, and the toe came into the chain. So this was the scar. Interestingly, this young lady has very black fingers. That means her energetic flow in all these 10 acupuncture meridians, the energetic flow, is totally blocked. In case this situation keeps on in Kirlian photography, you could say, oh, might be, when this keeps on for the next 10 years, this might end up in cancer. Okay? Might. Okay? It's no diagnosis. What did we do? We took procaine. You know procaine? Of course. We were injecting procaine into the scar. This is called neural therapy. Do you know the term neural therapy? Very simple. Okay. And 5 minutes later, we made the next Kirlian photography. Just 5 minutes later. Hello. And what can you see? Abracadabra, abracadabra, the right toe comes up. I'm a lizard. I'm magic. Yeah? With 0.5 milliliters of protein, I can create organs. Isn't this wonderful? No, of course I didn't. I just here, yeah, was able through the protein injection to take away the characteristics of a disturbance field of this scar. Because this scar was able on an energetic level of our body to make this organ visible. That means these meridians here to make them vanish. Number one. And number two is, look at the fingers. Look at the fingers. This is a normal energetic flow now. That means, on an energetic level, please, through this protein injection, I was not just only able to create or to reanimate this organ, I also was able to harmonize the energetic flow in these 10 meridians and to bring this patient out of a possible energetic cancer situation. Possible. And only energetic, please. This is not healing cancer, please, please. Yeah. But this is fantastic. Yeah. And this is just an example to show you how important the term of disturbance field is, how the body is reacting on a disturbance field, not only on this on the physiological level, but also on this energetic level. So the scar has a double disturbing effect, local effect on the toe and a systemic or holistic effect. Well, sure, you already saw were a little introduced in these connections of teeth and meridians. We worked a lot of time with this holistic model, but now we are changing, because now through our research, which I would like to present you now, we could leave this energetic explanatory model. It's just a holistic explanatory model on energetic level. But now we can go to pure science-based biochemistry. So now, from this energetic introduction, what chronic strain, what chronic disturbance field is, now we go really into a science-based medicine. Now, I have a friend in America. His name is Jerry Bucco, Professor Bucco. Professor Bucco was dental pathologist, professor for dental pathology, oral pathology in Texas, Houston, on the biggest dental school in the US. And he was the one who already introduced the term of NICO in 1989 already. And why did he introduce the term of NICO? You perhaps know. NICO means neuralgia inducing cavitational osteonecrosis, because each time he got a pathological sample from his oral surgeon, these patients had trigeminal neuralgia or atypical facial pain. And so he always in these samples found fat, and so he called it here, as all these patients had this neuralgic pain, his scientific conclusion was, in case in jawbone samples is fat, is an osteonecrosis, this is inducing neuralgic pain. This is the reason why it's called NICO. Okay, and this is a patient here. She committed suicide because of her incomparable neuralgic pain, and she committed her dead body to Professor Bucco, cutting here the jawbone, and you see these cavitations. And now the question is, what is inside these cavitations? Is it air? No, it is fat. So we call it here, these cavitations filled with fat, we call them now fatty-degenerated osteonecrosis or osteolysis of jawbone, FDOJ. Just to stay correctly in proper terms, in case these fatty degenerations here are connected to facial pain or neuralgic pain, then we call it NICO. Then it's neuralgia inducing, okay? But many of the patients, and this is what Professor Bucco did not know, have these FDOJ areas, these fatty degenerations in jawbone, but they don't have facial pain. So they don't realize or recognize that this fatty osteonecrosis is housing inside their jawbones. So it stays just there. And all symptoms are, remember, below the symptomatic threshold, okay? So people are running around for years and years, for ages, and have no problems, no pain. Now, when we, this is already Professor Bucco did this. He wrote a big book about that. It's a book, Oral Pathology. This is the most sold book on oral pathology worldwide. He described this as oil cysts. What are oil cysts? Oil cysts are confluent adipocytes. These are all degenerated adipocytes. And this is what we find inside the jawbone. And I'm personally scraping out for 45 years now these fatty samples out of the jawbone. Really, it is existing. Because possibly you hear about the opinion NICO is not existing. Professor Bucco is fighting a lifelong struggle about this term NICO in the US and worldwide. But he's absolutely right. And you see, this is like a little, like a chicken bone here, and this is the fat. And this is degenerated like this here. And this might be a living, a vital part of the bone here. So how about the extent here? Yeah. We see here, we filled in contrast medium here, just to demonstrate how big the extent of these FDOJ areas can be. It's not just a pin, the size of a pin. It's huge, and not always, but sometimes the infraalveolar nerve is lying here like a cable inside here. And you see in these areas, even the contrast medium didn't go in, so it's huge. And when we scrape out this, it's all these fat samples here. And now the question is, what is inside this fat? And the idea is very simple, basically. But for 50 years ago, I was the first one and the only one, and I'm still one of the only ones here. We know that fatty bellies here, the fat here, especially in men, not so much in women, but especially in men, is provoking cancer, heart attacks, infertility, whatever it is. This is why we should eat properly, feed ourselves properly, why we should have sports and so on to prevent these fatty bellies. My question was, I called my friend who was in charge in a lab in Munich and asked him, can you check for cytokines or what cytokines are inside these fatty samples? 15 years ago. 40 years ago, these modern methods didn't exist. Oh yeah, here's another picture, and you see like this here. Yeah. Here you see the nerve, the infraalveolar nerve, totally denuded here from its bony sheath. Okay, it's gone. And left and right and underneath here, it's easy with a sharp spoon to scrape out or even to suck out this fat. It's sometimes really just liquid. Yeah. And this is the end here. And you can do these surgeries here, carefully please, carefully of course. You can do this without any paresthesias of the nerve. Yeah. And it's obvious that this patient has a trigeminal neuralgia because the nerve over the length of 3-4 centimeters is embedded inside these fatty degenerations. These are the patients we live from for 40 years now. Now, basically we sent here these, we started to send these samples to the lab. We have one in Munich, we have one in Berlin, and they are checking with BIAT-based multiplex analysis here for cytokines here. And this is our routine panel now. You know, we have about 26 cytokines. We started with 5 samples, checking for 26 cytokines. And out of these 26 cytokines, only 2 cytokines came up with a cytokine overexpression in RANTES and in interleukin-1 receptor antagonist. So we built up this panel here and FGF2, but we leave it out. Yeah, so. And now I will present you this panel with 7 cytokines here, interleukin-6 and so on, MCP1, TNF-α, in many other examples here. So we checked this for cytokines. What did I expect 15 years ago, basically? Inflammation, chronic inflammation, okay. What are we trained as dentists in university? Chronic inflammation is TNF-α high, okay. When you have a bleeding periodontitis, what is high in a bleeding periodontitis? TNF-α, okay. When you have an infected tooth, apically, what is going high on the apex? TNF-α. TNF-α is producing pus and provoking pain and so on and so on and so on. Okay? I will explain this immediately. Now, these columns here, red columns, are the medium level, the medium value FDOJ, fatty degeneration of osteonecrosis here, fatty degenerative osteonecrosis in Jawbone, of 128 of these Jawbone samples, okay? It's just the medium value of 128 samples. This is what I promised you in the beginning. We only present here science-based data, okay? The multiplex machine is from America. It's built from Merck company, also used in Texas, costs about 1 million euros. Okay? So we are doing these consistently. And now, this is the outcome. And it's just one cytokine which is consistently in each second of your life producing when you have one of these samples here in your jawbone, one of these inflammations in your jawbone. Yeah. Yeah. And this is RANTES. And now the question, why is this fatty degenerative osteonecrosis of jawbone not doesn't make any pain or pressure, yeah, or inflammatory symptoms like swelling. Why? And the answer is very simple. Because in these 128 samples, we had low TNF-α and low interleukin-6. Blue columns here are normal jawbone, normal bone marrow. Where did we get normal bone marrow from? Quite easy. When we insert implants, okay, the core is coming up, we are checking this bone. And now you see here, TNF-α in this fat is only half of the expression intensity. Here, it's in the fat, only half of the normal value. And interleukin-6 is 5.5 inside here, and in the normal it's 100 about. So this is about 20-fold higher in normal jawbone than in this fat. And what is TNF-α and interleukin-6 doing? These are the ignitions of our immune system, okay? TNF-α high means, oh my God, I have swelling, I have pus, I have infections. Yeah? Same with interleukin-6. And these two signals, interleukin-6 and TNF-α, are lower in this fat than they are in healthy jawbone. And this is the reason why patients have these things in jawbone for years and years and years, and nothing happens. Okay? Everything below the symptomatic threshold. This is why you remember the picture, the wonderful red picture before? Yeah. This is very important to understand that. Now, the question is, why is RANTES of interest for integrative dentistry? These RANTES sources are inside the jawbone. They don't hurt, okay? They don't create pain. Why should we take care of these RANTES sources? No? Leave them. Nobody is suffering from that. Is this true? No, this is not true here. Because now, from the latest research, we can say RANTES is the, from me, newly detected interface or impact of integrative dentistry and medicine. RANTES is an abbreviation, of course, means regulated or on activation, normal T cell expressed and secreted, and basically it's a chemokine ligand 5. CCL5 is the more modern name, please. RANTES was detected about 25 years ago, Stanford University. It's not an idea of alternative dentistry, please. Here, RANTES. And now the more modern name is CCL5, chemokine ligand 5. Here. Looks like this. Okay. And you see normal T cell expressed. It's important. You know, T cells. T cells are the center of our lymphatic immune system. These all are T cells, okay? Though it's not just one finger somewhere in the universe. It's an important part of our immune system. So this is my friend, Professor Peter Nelson, just to give you credibility about this subject. He worked for 20 years in Munich on the university. Is working 25, he was part of this detection of RANTES at Stanford University. His papers have 16,000 citations. And we are quite good friends now. These are just two of his papers. RANTES, chemokine expression in cell-mediated transplant rejection of the kidney. What was his job in Munich University? Here, transplant rejection. They realized they do a lot of transplantations, okay? Kidneys, liver, heart, yeah? And each time these organs are rejected and the transplantation fails, RANTES is high. High RANTES is connected. And this was his research here on the University in Munich for 20 years now. Yeah. Or for instance, the RANTES deposition. We have the connection by platelets triggers monocyte arrest on inflamed and atherosclerotic endothelium. That means here RANTES is also responsible for atherosclerotic diseases. Now, okay, pink elephant in the room, number one, is this local RANTES overexpression FDOJ marrow defects of interest for general health? Very simple. I invite you, in case you have your laptop or something in front of you, it's no problem, go to Google Scholar. You know Google, of course. Google Scholar is the medical library of Google. Type in Google Scholar, very simple. Then go to search and go to, let's say, prostate cancer. Then Google Scholar gives you here 3,480 papers which try or are working on the connection of RANTES and prostate cancer. As you type in prostate cancer, you type in RANTES, and please also CCL5, so you get the more modern papers, okay? Very simple. 3,000 papers. When you type in breast cancer, where is breast cancer? Here, breast cancer, you get 5,000. So 5,000 medical scientists are working or were working or thinking or publishing or whatever on a possible connection of RANTES and breast cancer. Multiple sclerosis, you get 5,000. And so on and so on. Parkinson's disease, you get 1,300. Yeah. So it's quite easy to build up your own diagram. This is no secret. But it's impressive. And it shows how important it could be when dentists know that chronic RANTES input, chronic RANTES inflammatory signaling pathways are activated by our jawbone inflammations. Funny, when you type in jawbone and RANTES here, jawbone and RANTES, you get about 30 or 40 papers only. And from these 40 papers, about half of these papers are from us. Mainstream dentistry doesn't care. They don't care about RANTES. So, just some citations from science-based literature. RANTES can have detrimental effects via the recruitment of immune cells that enhance inflammatory processes such as arthritis, atopic dermatitis, I will show you a case then, nephritis, colitis, and other disorders. So this is more or less an order from science-based literature for us dentists, to follow RANTES expressions in jawbone. Or RANTES targets the central nervous system and is able to cause multiple sclerosis, and Parkinson's disease. In targeting mast cells, RANTES causes allergies, alopecia, and thyroid disorders. And here's always the citation. Oh my God! So in case you have alopecia areata, you have a patient. We have several ladies and several male and female patients, losing hair, being very unhappy about these, looking like a monk, badly shaved monk, or we cured them because RANTES is provoking inflammations of these sockets from your hair, and then they have an inflammation in the hair socket, and then you're losing the hairs. And so, interestingly, we thought, we took 21 patients with chronic fatigue syndrome and we took 48 patients with tumors out of our clinic, because we have only patients with tumors, with multiple sclerosis, and so on. They come to us and are searching for cure, or searching for relief, at least, of their diseases, systemic diseases. So we thought, oh, is there a difference in RANTES expression in the tumor collective or in the chronic fatigue collective? This is the only difference, interleukin 6, interleukin 8. But you see, RANTES CCL5 in these jawbone cavitations is in each group the same. Yeah. What does this mean? This means we have a very unspecific chronic signal, let's say RANTES, which is creating many, many different specific diseases. Yeah. And just here, because we have always chronically this high RANTES overexpression. And this reminds you of this picture, okay? But it's not the same. It's nearly the same. But here we have 23 breast cancer patients, okay? And the red columns are the medium values of 23 breast cancer patients. And the same come out. RANTES is high, TNF-α is low, interleukin 6 is low. Always RANTES. That means these 23 breast cancer patients all had here RANTES. Yeah. And you see, this is normal, RANTES here, 150. So there is a slight expression, chronic expression of RANTES even in healthy jawbone, okay? Why? What is the reason of RANTES? Why does the body produce RANTES? What is the sense behind RANTES? RANTES, chemokine ligand, please, is the attractor of immune cells. That means when you cut your finger and you have a wound, inside the wound, RANTES immediately goes high and is attracting lymphocytes and leukocytes into the wound, okay? So RANTES is the guarantee for wound healing. But when the wound is healed, RANTES goes back again, okay? RANTES is like the fire brigade in your village, okay? The fire trucks are in the garage, okay? The fire brigade trucks are in the garage. In case a house is burning, they come out. Da-da-da-da-da, okay? There's a big rumor. And when the fire is extinguished, the fire trucks go back to the garage. Imagine what happens in your village in case these fire trucks go around the village all the day without burning house. This is crazy, it's producing chaos. But this is the reason when this wound is not healing properly, okay? Then the body says, the wound is not healing, we need high RANTES. Huh? And so chronically, over years and years, RANTES will stay high inside your wound. This is probably not the case in the finger. But this is the case when we extract the tooth and the wound is not healing properly, okay? This is the case when we take out a wisdom tooth in a big surgery. This is the case when we insert an implant into a badly healed wound. All these actions might, in case the wound is not healing properly, might produce high RANTES. And I will show you later why is RANTES oversignaling in jawbone, in my opinion, nearly epidemic. Because we all have so many burdens, toxic burdens from the environment, stress psychological stress from profession or whatever it is? Or is it our mobile phones or whatever it is? Yeah. Which is limiting chronically our ability to adopt properly. You remember this figure? Yeah. And then we have no proper wound healing. Taking antibiotics is taking away the pain, is taking away the infection, the sepsis or whatever it is, but is not, definitely not a guarantee for a proper wound healing on a long-term aspect. And so you see, back to these breast cancer patients, 3 of them have the maximum. This is the old machine, now we have a newer one. 10,000 picograms was the maximum. And 150 should be normal, okay? This is nearly 1,000-fold higher RANTES expression than it should be. And this is the medium value. Yeah. So, what is the conclusion? I'll show you next one here. Now, interestingly, we found 2 science-based scientific papers here. This is the citations here. Plasma RANTES levels, disease course in patients with breast or cervical cancer. Here, breast cancer and so on, implications. And they checked the RANTES contents in breast cancer cells directly, okay? They found, they found in about 20 patients, they found 1,000 picogram of RANTES inside breast cancer cells. They found about 800, it's nearly the same, okay? So breast cancer cells express or contain about 1,000 picogram of RANTES. What is the RANTES expression inside our jawbone cells, fatty-degenerative jawbone? It's 5,000. It's 5 times higher than in the breast cancer cells itself. What does this mean? Is this RANTES coming from breast cancer cells? Or is this breast cancer cell RANTES contained coming from the jawbone? Yeah, the answer is asking this question is answering the question, of course. In biological systems, okay, we go from higher concentration to lower concentration. Quite easy. Yeah. So this is a proof that this RANTES might be, we don't have the, in medicine, nobody has 100% proof, okay? This is medicine. But we have here a hint, an idea that this RANTES contents in breast cancer cells might be induced or propelled by this high RANTES. So, RANTES expression FDOJ in these 23 breast cancer cases. Now we have about 190 breast cancer patients researched, 35-fold higher than in normal jawbone, 5-fold higher than in breast cancer tissue itself. Now again here, this is a citation from Nature. Okay, you know Nature? Yeah? It's a highly ranked paper. When you are allowed to publish in Nature, you are close to the Nobel Prize. The body's own stem cells stimulate cancer cells to mutate, to spread, and to form tumors in other organs. This enhanced metastatic ability. Now we are talking not about the primary tumor of breast cancer, we are talking about the metastatic ability is reversible, is reversible and dependent on CCL5 RANTES signaling. This is a paper from Nature. What does it mean? That means this RANTES, this oncogenic RANTES signaling in jawbone, okay, to the breast cancer cells is reversible. You can reverse the process, yeah, in or by diminishing or eliminating these RANTES signaling inside your jawbone. So this is a wonderful dogma for us dentists to do this jawbone cleaning, to do this debridement, surgical debridement of RANTES sources, to scrape out these fatty things here. Again, RANTES and its role in breast cancer. RANTES has been associated as well with the induction or promotion of cancer. Look here, this is the title of this paper, The Inflammatory Chemokines CCL2 and CCL5 in Breast Cancer. Development of breast cancer is the potential ability of RANTES to act directly on the tumor cells and to promote progression of the tumor. This is why we have many, many patients, they know from our research, which are coming to us. They have a diagnosis, primary tumor. Yeah, we always say, please have the tumor treated. We are not oncologists, okay? But the possible background, the possible cause why you got breast cancer might be RANTES. And I tell you, these patients always start crying because they say, you are the first one to tell me why I have breast cancer. Yeah? Some say it's my husband, some say it's my profession, yeah, and some say it's my dog or whatever it is. Yeah? No, this is a possible reason, very simple. Or analysis of RANTES expression demonstrates that expression of RANTES in breast tumor cells is elevated significantly. Breast tumor cell-derived RANTES might promote breast cancer progression. Okay, so RANTES itself is propelling the tumor inside the organ. And the same is for prostate cancer, okay? But it's boring to cite all these things, yeah? Prostate cancer is the same literature. It's not only women, it's same as with men. Now, this is a patient, she was, in the meantime, she died, but she was a professor for saxophones, you say saxophones? Saxophone? On the university in Vienna. She came to us. Clinics say, oh, you are tamoxifen resistant breast cancer, okay? She has a relapse, and so they said, we cannot do anything for you. This was 10 years ago. So we made an OPG, and look at this. This is the left lower wisdom tooth area. Would you, as a dentist, do a surgery there? Is the bone here looking nice? Yes, it looks nice. Yeah, yeah. But we did it because we made our ultrasonography. So we measured the bone densities there with ultrasonography device, with the CaviTAU. And we cleaned this out. And what came out here when we checked it in the lab in Berlin? Extremely high RANTES 4,600, okay? 150 is normal. Just remember, 150 picograms per milliliter. Here we had 4,000. And what happened? We also sent, we always do this, made a pathohistological sample, sent it to the pathologist. And he called me and said, could it be that this patient has a breast cancer? I said, yes. And he found metastasis of adenocarcinoma of breast cancer here inside this jawbone area. So this X-ray fails under a double important immunological aspect. Doesn't show RANTES, doesn't show here the metastatic cells of the adenocarcinoma of her breast cancer. Interesting, isn't it? And this is how it looks like. You fold back your mucoperiosteal flap, you open the cortical window. The cortical rim is always perfect, okay? This is nature. Nature is very wise, because otherwise we have consistently broken lower jaw bones. When you bite into your croissant at breakfast, it makes crack, but it's not so. It's only the bone marrow. So we have fatty bone marrow defects. This is basically what mainstream dentistry knows and calls it edema, bone marrow edema. This is a mystic term, bone marrow edema. They are talking about it, but nobody has a proper explanation. We have. Bone marrow edema looks like this. It's fat. And this fat is consistently producing RANTES. And again, you see here little parts of spongal bone here, some trabeculae. And the pathologist would say, this is living bone. But the rest around it is just fat. And inside this fat, you have these metastatic breast cancer cells here. This is the patient. Scrape it out, take it out here. And okay, and this patient lived 10 years. Her body was full of metastasis. And she lived for 10 years happily. For another 10 years after our surgeries. We did 3 in other areas, but this is just one very impressive one, to open the bone and you see that. And I'm sure many oral surgeons know this, but they don't know what it is. And they push it away and they say, okay, we close it again, close. So forget it. And this is not good for the patient's immune sustainability, because this is damaging his immune system. And this is what science-based literature well knows. Now, let's go away. Let's go to neuroinflammatory and neurodegenerative diseases. Here is a paper here. RANTES correlates with inflammatory activity and synaptic excitability in multiple sclerosis. RANTES levels in cerebrospinal fluid of MS patients. This is a research. Controls, patients without MS. Controls, patients with MS, but no attack, no sudden attack. Patients with high multiple sclerosis attack at the moment. And what is in cerebrospinal fluid? RANTES contents is 1,000, let's say 300 in the cerebrospinal fluid. Here, literature, cerebrospinal fluid levels of RANTES were remarkably high, only in active MS patients. RANTES correlates with inflammation and synaptic excitability in MS brains. This is what science knows. This is not from me. I'm a simple dentist. And here we have now 5 patients with ALS. You know ALS, amyotrophic lateral sclerosis. To tell you a story, I started my clinic in Munich, my integrative dentistry, integrative oral medicine clinic in Munich, 43 years ago. And let's say until 20 years ago, I didn't know what ALS is, because we didn't have ALS patients. And now, I'm sadly to say, now we have 1 to 2 ALS patients per week. And our youngest ALS patient is a 16-year-old girl. So this is a dramatic development in the last, let's say, 20 years. And all these ALS patients come to us very late, unfortunately. Most of them are talking to us already by iPad, because their voices are paralyzed. Most of them want, we try, but I have only one case where we're successful. This is a famous actor in German TV, but all the others died. So here, a preventive aspect would be so great in case dentists and doctors would know about these RANTES in jawbone and these RANTES connections to heavy, severe immune diseases, we could save many, many lives and many do good for people here. So these are these 7 cytokines in ALS, jawbone. It's the same, 4,000, RANTES high, TNF-α low, interleukin-6 low. It's always the same pattern. Yeah. Again, here we have an unspecific inflammation creating many, many, many specific immune diseases here. Okay, just a short summary. FDOJ is characterized by fatty-degenerative softening and osteolysis of jawbone. Is characterized by degeneration of adipocytes here, lack of typical leukocytic infiltration, no swelling, no pain normally. FDOJ is characterized biochemically by high levels of pro-inflammatory RANTES in comparison to normal jawbone. FDOJ is characterized by absence of acute cytokines such TNF-α or interleukin-6, which explains the painless and cryptic nature of the FDOJ. Yeah, this is the very, very important sentence. By the way, if you want, just send me an email, okay? You can get these PowerPoint slides. This is not a secret. We want to spread the knowledge. It's very important. Okay. Again, collectively, our data reveal a chronic inflammation in jawbone, chemokine RANTES. RANTES CCL5 is well known to propel many systemic immune diseases. Sources of RANTES is the ischemic, very important, ischemia, ischemic. This makes it really hypoxic, ischemic. This makes these, to do the surgery on these chronic inflammations is easy. You have no bleeding. Yeah? You just suck off and scrape out the fat. Okay? Very simple. Yeah. To do a complicated wisdom tooth surgery is much more complicated than this. Sources of RANTES are ischemic fatty degenerative areas in jawbone. And this is very important. This is why I'm here. And this is why people do mainstream dentistry and even mainstream medicine are neglecting and are not aware of these phenomena, because the imaging here in OPGs and CBCTs here is not reliably. Otherwise, they would know, they would discuss it. And so to make it visible, we developed this ultrasonography device here, and this is crucial in case you would love to practice integrative oral medicine or integrative dentistry in your clinic. So this I already showed you. It's over there, these little booklets here. Oh my God, I published this in 4 books in German, in 1,000 pages, 800 pictures, and we compressed it here in English, Cavitation, Osteonecrosis, and Jawbone. You can order this book. It's, how much is it, Robert? 69 euros. It's cheap anyway, because we want to spread the knowledge. Inside are all these pictures. I showed you. We have this book already also in Portuguese. Is anybody speaking Portuguese here? Probably not. We also have it in French. And we have one of these books even in Chinese. So we are worldwide present, and we would love to invite you to be member of this worldwide network. And the worldwide network, if you want to become a member, here are the application forms in English. Here, it's only 100 euros per year, and so you are the member of ICOSIM. ICOSIM means International Scholar International College of Maxillomandibular Osteoimmunology, okay, to emphasize this term of osteoimmunology in dentistry. Yeah. The connection from osteo, from bone, to immune system. These things are over there. Yeah. You're caught ladies first. Yeah. I want to show you our immunohistochemic research and the immunohistochemic staining of the FDOJ to show visually the RANTES depots in FDOJ. And again, here we are the first ones worldwide to do so. And it's very simple. We also published this, PubMed indexed. But for instance, here you see this area here, maxilla, here, looks nice on X-ray. But when you open it, when we scrape it out, the softened bone, and we send it to the lab, we have 2,500 of RANTES compared to 150 healthy. And our pathologist was able to stain it with a so-called anti-rabbit antibody here. And everywhere where you see it red here, you have RANTES nests. Yeah. This is part of your FDOJ here, microscopic here. And here you see the RANTES nests. This is one of these samples. Again, another patient here with, this patient is with breast cancer here. Again, you see these RANTES nests. Again, maxilla here, 1,500. And of course, we can, in breast cancer patients, which are, these are not our patients because I'm not doing breast cancer, but the pathologist is also able here in this breast cancer tissue to immunohistochemically mark these RANTES expressions here, okay? We can make it visible where it is. And this is also here breast cancer and associated connective adipose tissue. RANTES stained cells here. Yeah. And this is on another paper, you know, it's on pancreas cancer. These are pancreas cells where CCL5, our RANTES, the ligand, and the receptor are low. This is higher, and this is really here strong pancreas cancer, pancreatic cancer cells. Just to show, scientific research well knows about this. Yeah. And RANTES in connection to pancreatic cancer, you know, pancreatic cancer is a problem. Yeah. So in mice, we can, if they block the CCR5, the receptor in mice, okay, and in mice with pancreatic cancer, and they block this, the RANTES receptor, in 6 weeks, the pancreatic cancer shrinks down to 50% of its volume. And if we would have pancreatic cancer, the surgery is often not possible because it's too big. So in case in pancreatic cancer patients, it would be possible to block the receptor, the RANTES receptor, in these pancreatic cancer cells. The cancer would shrink for 50% in 6 weeks. Which famous guy died of pancreatic cancer? Apple, Steve Jobs. So in case Steve Jobs would have been a mouse, we possibly could have saved him. And I don't know about his jawbone. would be interesting, yeah, how far his jawbone possibly was expressing chronically higher RANTES levels. This is a patient with ALS, and again, we measure not only RANTES in FDOJ, we also make it visible with immunohistochemical staining. Okay? This is very, very interesting. Okay, this I already showed you. So let's go to the next one. Now, I would like to show you some clinical cases, because we all are, or you all are clinicians and not only researchers. This is also published in PubMed. So when you go to the QR codes and go to PubMed, you find all my, up to now it's 25 papers from me and our team. The title is Linking Dentistry and Chronic Inflammatory Autoimmune Diseases. Can oral and jawbone stressors affect systemic symptoms of atopic dermatitis? Here, we love to call this item immune dentistry. Okay, holistic dentistry is a bit old-fashioned. Holistic is a bit esoteric. Immune dentistry, we are dealing with immunology. So this is a patient. She's coming like this to us. She is 48 years old. She was a member of a TV team, RTL German television. And this is how she looks like. Chronic atopic dermatitis. Twice from dermatologists, she was wrapped in twice for 1 week in cortisone all over body. Effect? None. And so on and so on. So she's coming like this, with her arm. Now, looking at what is science knowing here, RANTES and inflammation. RANTES is a mediator of acute inflammatory responses. RANTES plays a fundamental role in histamine and serotonin generation and cell function in mast cells. This is what I already told you. Yeah? Mast cell hyperactivation syndrome. MCAS, it's in English. Mast cell activation syndrome, MCAS. Yeah. It's a very, very difficult to treat disease. We have some patients and we cured them. Or in a study of atopic eczema, RANTES and receptors, always important, RANTES alone is just the messenger, okay? So there's a science, a Chinese paper, in about 25% of Chinese population, we have a RANTES non-sensibility. That means they have high RANTES, but the receptor is not reacting, okay? So they might have RANTES in jawbone and have no consequences, overall impact from these local sources. So in case you have RANTES in your jawbone, don't be afraid to die from prostate cancer, breast cancer, whatever, okay? It depends. So RANTES and its receptors, CCR3, CCR5, CCL5 is the ligand, and we have several receptors, but they also react CCR3 with CCL5 here. We're shown to play potentially important roles in the orchestration of eosinophilic infiltration in the ongoing chronic inflammation of atopic eczema. And this is a wonderful patient for atopic eczema. Now, I would show you how we start in a patient like this here. Of course, we start with oral imaging. We make an OPG, and then we make the ultrasound, the ultrasonography. Why? Because you and we in Germany and in the US And in each civilized country, what do we have? We have a radiation protection law. And part of this radiation protection law is this ALARA principle. Sure, you learned that in radiography. As low as reasonable, acceptable. Okay? So it's not by law immediately to take a CBCT, because here you have a high radiation impact. It's better, and we say this, and our patients are really, really happy to get that, because they are coming and are having 1, 2, 3 CBCTs from other dentists, and patient says, nobody is finding something, nobody is doing anything. Yeah. No consequences about that. And then we say, no, we don't do another CBCT. We make first, okay, a non-damaging, non-radiating ultrasonography. Yeah. And in case in the ultrasonography with which we measure the bone density, we see the areas where the bone density is limited. Of course, healthy jawbone has a dense structure, and FDOJ areas have a soft structure, contents. And this is easy to find on this ultrasonography. I will show you later, okay? So next thing is we measure the oral toxicity. That means in case patient has root fillings, we measure the volatile sulfur compounds, the toxic thioether, mercury compounds coming out from root fillings. Root fillings are, I say, are toxic. Not in the first 3-5 months of the treatment, but later. This is an extra seminar, okay? I would love to come again to Vilnius and to talk about this. So next one is we check the immune system in the serum, take out serum. We, my friend in Berlin, Volker von Baer, IMD Berlin, IMD Berlin, imdberlin.com. You get all informations. He developed a titanium stimulation test. That means how far is titanium stimulating the immune system. And we realize that about 20-25% of our patients have oversensitivity to titanium. The saying, the dogma titanium is compatible for everybody, is not true. Okay, next one is the toxicity from root fillings is the volatile sulfur compound. Okay, these are the toxins, and this is the immunological test check of these volatile sulfur compounds. It's all in serum. Yeah. Yeah. Second, we are checking for dental materials compatibility. This is the LTT, lymphocyte transformation test. Everything is offered by IMD Berlin, okay? And at the end, we measure RANTES in serum. In case RANTES in serum is above 30 nanograms per milliliter, I emphasize this, it's in serum we have nanograms. That means we have a 1,000-fold higher concentration than the picograms in the jawbone, okay? In case RANTES in serum is above 30 nanograms, you can say possibly this patient has FDOJ, okay? This is a rough diagnosis. Then we do the surgery, okay? And during surgery, we do the histology, the pathological finding. We scrape out the RANTES, the FDOJ sources, the FDOJ, and send it to the IMD Berlin. This is our pathologist. And then at the end, we make a control imaging. In case you doubt for a foreign body, of course, you make your OPG. But 4 to 6 months later, we always check with the ultrasonography, okay, harmless, no radiation, yeah. We check for the proper wound healing. Just to show you where in our protocol here, the ultrasonography here, yeah, is really a crucial item. Now, back to this patient, yeah. This is how she's coming to us, okay? All her dentists say it's fine. She can chew on all these teeth, okay? She has no pain, no problem, yeah, in the oral cavity. Yeah. And this is, what you see here, is the ultrasonography. So, when you go to area number 19, unlike an uneven mainstream dentistry, we do not stop with number 8, okay? You also have the European counting, yeah? Not the US, yeah? Okay. That's fine, wonderful. Because in the US it's getting complicated to explain this. 19 here, because these retromolar areas in maxilla and mandibular, yeah, have a high extent of the FDOJ, okay? Don't forget these areas. In case you do a surgery, maxillary, mandibulary, doesn't matter. Try to go far behind, yeah? I will show you some examples then. So number 19 and 18 here, this area. 17 here is totally green. Now, very simple. Ultrasound, our ultrasound device, the CaviTAU, has a very simple imaging. Green is healthy jawbone, okay? Dense materials like healthy jawbone, dental roots, okay? Crowns, yeah? Teeth, this is all green, okay? The frequency is like this, so it comes up green. In case here the density is lower, going down to fat or even liquid, it's coming up red, okay? So when you look at this here, you know, red, here is your silent inflammation. Red is silent inflammation, very simple. And you see, this is all okay, we didn't measure this. Number 2-4 now, here, 1, 2, 3, 4, this is a healthy tooth. But 2-5, the root filling, you see, huge here, red around this root, okay? And now it's very important. This shows you already, it's not good just to take out this tooth. You also, in the same session, have to clean the apical area around it, yeah? Because only extracting root fillings, yeah, is not a proper procedure in our means regarding osteoimmunology. 2-8 to 9, again red, and here it's dramatic. Here, dramatic. Yeah. Oh my God, what to do with this lady? Yeah, taking out all these teeth and implants. I will show you. Number 3-3 is healthy. Yeah. Now I know to compare this one with this one. Yeah. Here we have a big difference here in this apical area. Osteoimmune reactions. Same here in this area. Yeah. Okay. So we did this. We followed this ultrasound protocol step by step. This is how we do it. Ultrasound, very simple. We have a sender outside and a receptor inside. The receptor has the size of a fingernail corresponding to an odonton, one tooth. This is a LED, so you can see where you are. Yeah? You know where you are. And you go there, make click, next, click, make click, click, and so on and so on. So just example, here looks nice. 3, 7 is green, is healthy. 8 and 9 are not good. You can enlarge these measurements here. I will explain this later. And you see it's red here, some yellow here. So this is not good, but it's not as bad as this area. This is really fat here. And this is what is coming out. These are some FDOJ samples of this lady. Okay, just some. Here is a sharp spoon, where we scraped out the fat. This is the fat, looking here. This is a comparison. We prefer ceramic tools because we don't want metal parts in the jawbone. So we have a ceramic drill. The diameter here is 0.9 millimeters, and you see what extent is coming out of this patient from one side. What are you seeing here? This is fat, you know. You remember your mother's good chicken soup, okay? What is on top of the chicken soup? These fat eyes. Or Professor Bucco, my friend Professor Bucco, Jerry Bucco, is calling these oil cysts because it's like oil. Now the mean value, the RANTES mean value here altogether, it's not so important. The medium value of all these FDOJ areas is 2,100 compared to 150. It's huge. So we have the proof that what we took out of her jawbone is RANTES expressing pathology, pathologic, changed, altered jawbone. Now, going again to Google Scholar, search for neurodermatitis and RANTES CCL5, and you get here 89 results. For instance, there was a significant association between the upregulating variant of RANTES and atopic genes and atopic dermatitis. These results support a role for RANTES promoter polymorphisms in susceptibility to atopic dermatitis. Here. Or these results suggest that RANTES, as well as its receptors, blah, 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 may role important roles in the orchestration and so on. Here in atopic eczema, I showed you just before. Okay, so it's not a bad idea, okay? It's not a weird idea. If you have a patient with atopic dermatitis or a neurodermatitis, to check for RANTES sources, okay? Best with ultrasound device, non-radiating ultrasound device. And in case in the ultrasound these red spots show up, you can tell her this might be the reason for your dermatitis. So this is what we are doing. This is a picture of one of these wisdom tooth areas. Yeah, fold back. This is also already cleaned out. It looks nice now. Or this is the left lower. You remember in left lower, oh my God, we took out one root filling, we took out 2 implants, and so on, and it looks like this. So we made a grafting with her own bone. Yeah. Why own bone? Not to provoke further autoimmune reactions, you know, by porcine or other substances. So we insert 3 implants, ceramic implants, no titanium. I started nearly 20 years ago with ceramic implants from my friend Ulrich Volz in Germany, which is selling SDS implants. We can recommend that. And I inserted in the last 20 years about 4,000 ceramic implants. This is nice. This is not a big issue. Easy. And now these are the implants. Here in these areas we did the surgeries. Okay, you remember? And this is the control. And you see, oh, wonderful. Here is all green now. Oh, perfect. We eliminated all these RANTES sources step by step. Okay? Doing surgery, waiting for 4 weeks. Doing surgery, waiting 4 weeks. Doing big surgery, yeah, waiting for 6 weeks. Just to give the immune system a chance to recover. Okay? It's not to pull out many teeth and to do many FDOJ surgeries in one session. Okay? This might be a big relief for the patient. But your immune system is anyway weak, because otherwise you wouldn't have the symptoms. So you must give the chance, a good timeline for the immune system to rebalance, yeah, to come up. And now here we realize, oh my God, here where we did the surgery up there, either we forgot, I don't remember, or what we did was not very successful. Our attempt to bring this area to a proper wound healing failed, honestly. Same here. Okay? So eventually we have to redo the FDOJ surgery here and there. Eventually. It depends on the outcome. And this is the outcome. This is the patient today. 3 years after this check, 3 years after, okay? She came like this, and this is her face today. This is like grandmother and granddaughter.
And it's only after taking all these toxins, or maybe you did some detoxification extra?
We will answer this question a bit later. Yeah. What is the treatment around the FDOJ surgery, which is very important. Yeah, very important. But basically, that's going on. This is it. Yeah. And this is published here. Up to now, I think we have about 2,000 or 2,500 links, readers of this paper. Here. This is also a paper, a case report. Patient with chronic fatigue, also chronic fatigue syndrome and bone marrow defects of the jaw. A case report on additional dental X-ray diagnostics with ultrasound. We always want to emphasize that all these things we discover are connected with ultrasound diagnostics beyond X-rays. Because this is why the patients are in our clinic. And of all these patients, we are, of course, not the first dentists, but we are the first dentists to do the ultrasound. So the purpose of this paper, or the objective, is to demonstrate the additional benefit of ultrasound. A case of chronic fatigue syndrome, young man here came to us. He was unable to work. He was unable to continue his studies. He was 28 years old here, and he came to us, had many CBCTs and so on here. But however, the measurement of our bone density using, and we call it transalveolar ultrasound. Why transalveolar? Very simple. We have a center outside and have a receptor inside. Okay, so our ultrasound frequency are going through the alveolar bone and are received by the receiver. Okay, and the receiver has 91 piezoelectric pieces, little pieces, and they build up the ultrasound picture, where you can see is it green or is it red or whatever. And it's dependent on the attenuation. Okay? You know, sound. Sound is best conducted by dense material, yeah? Is less conducted by liquid, and it's least conducted by air. So basically we are using for our communication the worst medium for sound conduction. Yeah. Water is better. Yeah. So the attenuation of this ultrasound is higher in liquid or in fat than in healthy jawbone. This is the principle. Why is it not possible to use the ultrasound machine from your gynecologist? You know, babies. Huh? Many pictures are taken from babies with ultrasound. Yeah. This is the proof that ultrasound is harmless, absolutely harmless, in contrast to X-rays. Yeah? Would you, when you have a baby, when you are pregnant, would you go to a gynecologist? Yeah? And he says, okay, come on, we make an X-ray from your baby now. What are you doing? You are leaving this clinic screaming, hopefully. It's not allowed, it's forbidden, yeah, of course. Yeah. But ultrasound is okay. But this ultrasound is different. If you use this ultrasound here, the sound is immediately reflected by the hard surface of the cortical bone. So you never get an insight with this ultrasound here. Okay? So we need a different ultrasound. We need different sound frequencies. And this is a specific point of our machine, yeah, to develop these frequencies to get an insight into the bone. Very important, because some try to do it with this, or it fails, has to fail. So again, this is the OPG, the left lower area of this patient. This is the CBCT. Would you do, looking at this CBCT, would you do a surgery here, clean up surgery? Would you presume here is fat inside or something, pathological structures? I think no. But what comes up here, this is all red in this area here. So this red is indicating here the fat. What is this yellow here? This is also fat. What is this? This is the infraalveolar nerve. Nerves are fatty structures. So, of course, you could immediately throw out our CaviTAU device if this device would not be able to show this fat also. So yellow is the nerve, okay? Never clean out the yellow area with your sharp spoon. The patient will complain. But just over and directly lying adjacent at the nerve, you have the red, you have the softening, you have the fat, okay? Yeah, this is the schematic here, center, receiver, enaural, here, transalveolar, tau, transalveolar. This is the reason why the machine is called CaviTAU, cavitations by transalveolar ultrasound. Huh? Cavitations by tau. Here, outside, enaural center, going through the cheek, through the jawbone, here, and this is the receiver. Here it's green, and here it might be red. We use here gel pads. Did any one of you ladies have an ultrasound here, being pregnant on their tummy? Yeah. What is annoying? Annoying is the cold paste the doctor will put on your naked tummy, okay? This is here very important, because the severest enemy of ultrasound is air, okay? So when we have here the sender outside and the receiver inside, it's crucial to have something between sender and enroll which is preventing air bubbles or air fields in between. So we have demi-solid gel pads. Just put it over the sender, put it over the receiver, hold this inside the mouth here, and press. And so you get a good display in the ultrasound machine. But this is what you learn, of course, when you want to get a machine and when we educate you in this machine. Ruta is just out, but she was educated by us. It takes some time. So what did we do with this guy here? We opened the bone here, we opened the cortical area, and now we clean this out. And again, you see here at the bottom of the cavitation, you see the nerve. This was red in the ultrasound, okay? And this was, and this was yellow. This is the yellow part. And what is coming out? Fat, what we expected. But what is the black substance? We scraped out huge black soft substance. This is Aspergillus, Aspergillus niger. So this poor guy had two problems in his area, in his left lower wisdom tooth area. Yeah, FDOJ, fat, and Aspergillus. So the fat had high RANTES, 6,000, compared to this here. And when we check it here, literature, RANTES can have detrimental effects via the recovery of movements that enhance inflammatory processes inside the central nervous system. This patient, remember, is coming to us, chronic fatigue syndrome. Young guy, looking athletic, totally unable to study, to work, whatever, to live properly. And this is the point here, because X-ray, OPG, nothing. CBCT, German word is DVT, digital volume tomography, no reaction. Ultrasound, red, mostly red. So this is the poor guy with chronic fatigue syndrome. X-ray doesn't show, CBCT doesn't show. Ultrasonography shows FDOJ. FDOJ here in this area is producing RANTES, high RANTES, and RANTES is affecting the brain. Please remember, astrocytes are those cells which react most sensitive to the RANTES inflammatory signal. And through this reaction to the RANTES inflammatory signal, astrocytes are producing their own inflammatory patterns. So in case your astrocytes react on the RANTES signals, you have a low-grade encephalitis. This is the reason why I have many happy patients, mostly female, with migraine. Yeah, reducing the RANTES signaling, okay? You reduce the astrocyte inflammation. The brain is consisting for, I think, 60, 70% from astrocytes. So in case 60% of your brain is in an inflammatory, chronic, low-grade inflammatory pattern, your head, migraine is like this, like a bomb, okay? So it's just another target for RANTES, astrocytes. like the receptors in the breast, in the prostate, in the nerve sheath, wherever it is. Yeah. So second, he suffers from RANTES, chronic brain inflammation. And second is aspergillus, highly toxic, okay, damaging his mitochondria, these toxic mold toxins, damaging the mitochondria, low mitochondria, a very low ATP level. You know ATP, of course? Yeah. If you have no ATP, you have your Porsche in the garage and the tank is empty. He's athletic, this is his Porsche, but the tank is empty. Yeah. And this is just an interesting case here. I love to show it because we were really impressed what was coming out of this area. Nobody ever discovered that. He's from Switzerland. Yeah. I think we were dentist number 3 or 4 or 5, where he tried to get solution for his disease. Where did he send him? To the psychologist, of course. Yeah. He had, for nearly 1 year, he was in a psychological clinic. The outcome was poor. Of course, when you have this in your, each day, each second of your life in your jawbone. No. Okay. Okay. Ah, yeah. This is from the paper, the graphical abstract from this paper here. Also, improper psychiatric treatment here. So, dental X-ray, nothing. CBCT, nothing here. And the CBCT, of course, doesn't show the aspergillus. The gliotoxins are terrible. This is why you should not sleep with mold in a room with mold on your walls. Yeah. The problem is you don't smell it. But in Germany they have specific dogs. Do you know? Possibly here, specific dogs who can smell the mold. Yeah. So in case you're suspicious, yeah, try to get one of these dogs. Okay, so we check for the bone marrow defect here, and we find it with the we define it with the tau, with the ultrasound here, and then we clean it, and we find FDOJ and aspergillus, and here, so the toxicity from inflammation here from jawbone is connected to the chronic fatigue syndrome, and here we have the proper causal diagnosis. And this is just one of these patients. Huh? We do not publish each patient, of course, yeah, but this is the thing. Ruta was just telling them that we use, we have these gel pads around the center and the receptor. You saw these things, yeah? It's very simple, yeah, but it's crucial to avoid air in between of these measured distance between center and receptor. Yeah. And these gel cushions make it for the patient very comfortable. Huh? It's soft, yeah, it's not hard, it's nice. Number 9 area, we have, sure you also, it happens to you, we have some patients which have 2 wisdom teeth, a number 8 and a number 9. Yeah? Mostly small ones, but it's existing. That means probably from Neanderthals times, we should have 9 teeth. And this is a degenerated origin. And this degenerated origin leads to a non-healthy bone, yeah, to a fatty bone. Yeah. I don't have the example here, but you know I'm in Munich. You know Bayern Munich, the football team? I'm pretty close, though I had many patients from FC Bayern. They were in Dubai for training sessions, and the goalkeeper got nausea and vertigo. And they flew him from Dubai to Munich and checked him all day. Immunology, everything. Didn't find any. So I got a call from Dr. Müller-Wohlfahrt, from my friend Dr. Müller-Wohlfahrt, and we checked him, and we did surgery at midnight. Okay, for these guys, they are valuable. They cost a lot of money. We did the surgery on left upper area number 9. Beautiful wisdom tooth, yeah, not impacted, straight. We took out also the wisdom tooth. It's necessary to clean area number 9 properly. We cleaned it. Next morning, he was flying back to Dubai. And 3 days later, on a match in Salzburg, Red Bull, you know Red Bull? Red Bull Salzburg? Yeah. I think he was holding 1 or 2 penalties. Yeah. Immediately next day, it was gone. Yeah. You know, these guys are in a good regulatory situation, of course. Yeah. They're well trained. Yeah. And you do the proper thing, just 1 point. Yeah. It's a switch. And then immediately you get success. In normal patients, yeah, chronic patients, it's not only a switch. It's a hard work. Yeah. So I honestly don't remember this patient with chronic fatigue. He felt better, but I lost him then. Yeah, he went back to Switzerland. Yeah, so I can't say when he was really cured. But the picture from this lady, she loves to send us these pictures. Yeah, and she gives us the permission, of course, to publish that. Yeah. Funny story to tell you stories here. This is a patient with neuralgia things. This is German. She's 23 years old, and she has on the left side, left lower, she has chronic pain face, chronic neuralgic attacks here. No doctor was able to diagnose that. One doctor said it's incurable. When you get an incurable diagnosis, and when you are 23 years old and you get this diagnosis, this is depressing. This is her X-ray. Look, this is her X-ray. No root fillings, nothing. Yeah. This is left lower, left upper here. This is CBCT from left upper. This is CBCT from left lower. Yeah. We were number 3 making CBCTs. But first, we made the CaviTAU. And the CaviTAU is like this. You see, upper, right upper, okay, inconspicuous here. Right lower. Here you see again yellow and a bit red. What is this? This is wonderful, the intraalveolar nerve. Okay. Left upper. Yeah, okay, not so good like here. But left lower is dramatic. 3 weeks later, we did this, the left lower, 6,360. 150 should be. In the meantime, we have more than 3,500 of these single RANTES diagnoses. So we know by the lab, yeah, that in 3,600 cases, we were right. We helped the patient. Yeah. We have no guarantee how many immune diseases were cured by this. Yeah. But locally, we definitely did the proper thing. And this is the pathologic finding: interstitial fibrosis, single fat cells here, and they are always calling about trophic disturbances. What does this mean, trophic disturbances? That means we have a metabolic disbalance. No? It's hypoxic, okay? It's anemic. We have no blood flow. Yeah? We have hypoxia, yeah? Not enough oxygen. And then you get an oxidative stress in this area. Yeah? And the oxidative stress is changing your adipocytes to degenerative adipocytes. They are confluent. Look at these fatty ulcers. Yeah. This is a very simple, normal pathological procedure to develop this. And the funny thing is, when she came to us, beginning 2022, her biggest desire was to marry without facial pain, because she was sure her wedding would be destroyed or damaged, the fun, the joy, by this facial pain. This was her biggest desire. Yeah. And this is her wedding. She sent us the pictures without facial pain. Absolutely. And you see, this is a pretty young woman. Yeah. And the biggest desire for years of this young lady was to marry without facial pain. And now in 23, don't remember when, she did. Yeah. You see one of these nice, our Bavarian Catholic churches, yeah, full of gold and yeah, this is a nice story. Yeah, we made this lady happy. Yeah, and it's a 30-minute surgery. It's not a big issue. Yeah, it's a pre-treatment diagnosis, and it's a post-treatment. We discuss it later, and you make this lady happy. Unfortunately, she didn't marry me. She went on. Okay.
Certainly once toyed with the idea of taking his own life. Or he said so many times, this is not worth living anymore.
This is the wife. Okay. It's a video. This is one of the videos.
I tell the story of my husband, Mr. Meinolf Stromberg, who has been dealing with trigeminal neuralgia for 5 years. And at some point, we came across Dr. Leshnar and ended up there. A rather long story. It started 5 years ago. Actually, only that the nerve might have reacted, but then it got worse and worse, so that he could hardly speak. Eating was totally difficult, and brushing his teeth. Everything that had to do with his face. He had it on the left side, in the upper jaw, and did not dare to move his mouth. And he was already very desperate. My husband certainly once toyed with the idea of taking his own life. Or he said so many times, this is no longer worth living. Or he would no longer have any desire to live if it stays like this. X-rays were then taken at umpteen dentists, and they always said first, there is nothing there. Then suddenly an inflammation in the left upper jaw on the canine tooth, which was then root treated. After that, however, it was no better. In the end, the tooth was pulled out at my husband's request because he said, maybe when it is gone, it will be good. But that didn't help either. We then have a doctor in Wuppertal who said he can operate on the nerve. The nerve is sclerosed, and then no more pain is transmitted to the brain, and he would then have a new life. He did that, of course. After that, it was also good, but a few weeks later, the nerve starts again in the same way. My husband searched the internet and then came across your practice, and then we just called and said if we could get an appointment. Then we were there the first time only for the preliminary examination. Then it was determined by ultrasound that he has an inflammation of the jaw, that is, in the left jaw, above all, which no one has seen before. And then the next time we went straight to the operation. Then his jaw was opened and just all this bacteria, the RANTES, was removed.
Well, she doesn't know, but RANTES, but she's just telling.
And he had really no wound pain afterwards either. We were still in Munich for 3 days, and we were so amazed that it worked out so well. And after that, it was super good.
Danach war es eigentlich super gut. So 3.000 Euro gekostet.
It cost 3,000 euros. Before that, it was certainly a lot more. What we spent for all the journeys and for all the things that we did there. So we are glad that we went to Dr. Leshnar.
Froh, dass wir zu Dr. Lechner gefahren sind. Vorher
Before, it was really a huge effort to drive here and there, and it was all to no avail. And now that we've been to see Dr. Leshnar, he's doing well.
wirklich gut.
Vital, partly reactive, osteosclerotically widened bone tissue without evidence of active bone remodeling. Marrow interiors show on the one hand larger capillary proliferates, a mesenchyme with clearly increased lymphocytes, with interstitial fibrosis, with partly myxoid degeneration of fatty tissue-like structures. On the other hand, with evidence of at least moderate chronic and low fibrosing osteitis, but also with changes in the fatty tissue because of trophic.
Yeah. I just wanted to discuss this with you. Very important. The pathologist here is finding vital bone in this fatty degeneration here, partly reactive and so on. Yeah? Larger capillaries, okay, increased lymphocytes, interstitial fibrosis, and partly myxoid degeneration. What is myxoid? Myxoid is slimy. Yeah, slimy. This is the morphology which comes up. Yeah. Ah, perfect. And when I go back, here.
Before that, it was Dr.
Where's the surgery? I know the surgery.
He had really no. Then his jaw was opened, and just all this bacteria, the RANTES, was removed.
Yeah, RANTES bacteria is not true, but she's a lake.
Take long, and he really had.
And you see it scraping out. Yeah?
We were still in Munich for 3 days, and we were so amazed that it worked out so well. And
This is not the patient. The surgery is from another patient. Excuse us.
3.000 Euro gekostet.
It cost 3,000 euros. Before that, it was certainly a lot more. What we spent for all the journeys and for all the things that we did there. Vital, partly reactive.
So just to show you the idea of myxoid, and again, this is what they always find is trophic disturbances. Yeah, that means these areas are not able to show a proper osteogenic metabolic situation. Yeah, osteoblasts and osteoclasts are totally disbalanced. Yeah? Otherwise, we wouldn't have the fatty tissue. And he also defines a low fibrosing osteitis. Yeah. Low fibrosing osteitis. But it's not a direct inflammation, a specific inflammation. It's unspecific. So let's go to the finish of this patient.
Widened bone tissue without evidence of active bone remodeling. Marrow interiors show on the one hand larger
This is part of boring for you again.
changes in the fats like RANTES, CCL5, etc., play pivotal roles in neuropathic pain. Further investigations concerning the functions of the chemokine-cytokine network-mediated regulation of neuroinflammation may lead to novel therapeutic strategies against intractable neuropathic pain. Opioid receptors play an important role in CNS pain transmission, but are inhibited by RANTES CCL5, which increases pain signaling in atypical facial pain and trigeminal neuralgia ATG TRN. Therefore, it stands to reason that RANTES signaling should be reduced in ATG TRN. In 15 patient cases, the study proves RANTES overexpression and remediation, the therapeutic success of pain reduction.
Our own paper, okay. These are the 4 German books here. It's huge. So one of these QR codes is this patient here. We have another trigeminal neuralgia patient, similar, you can check. And in the afternoon, I will show you the report of the Parkinson's patient we cured totally. Yeah. And this is a nice booklet here, and you can order this for 60 euros, I think. Is it 30 or 60, Robert? And here, this is a documentation of 69 of these FDOJ samples here. And we have a color code, 7 color codes. So these are patients, these FDOJ samples are from tumor patients, these are from neuralgic patients, these are from immune disease patients, like allergy or something like this. These are rheumatic arthritis patients, and they all have these wonderful pictures, okay? And all about this, we published a paper where unfortunately the word NICO showed up in this paper. And immediately we got a letter to the editor from an oral surgeon in Boston. And I'm discussing with our oral surgeon in Boston now. And he says, NICO is not existing. Yeah, okay. This is NICO. This is neuralgia-inducing cavitational osteonecrosis, okay? And as we know now that RANTES is connected to cancer, in a cancer patient, it's not a NICO because he has cancer. It's a, we could say it's a KICO. And as we know that RANTES is inducing rheumatic arthritis in some patients, it's a RICO. It's a rheuma-inducing cavitational osteonecrosis, okay? So the term NICO is correct, yeah? But it has a bad history about it, yeah? There was, in America, it's a bad history about NICO, unfortunately. It's a long story. This is a lecture which I was talking in Nice last year, France. And are you familiar with the name Joseph Choucroun? We are good friends, Joseph and us. And he was the first in France last year to make a congress with the name osteoimmunology. He also understood what osteoimmunology is. Yeah? He's also buying a CaviTAU for France now. And this was a huge congress, 600 attendants. And I was talking about facial pain and osteoimmunology here. Besides, this is wonderful Munich. And sometimes, not always, we have warm winds from the south, from Italy, and then you really see the mountains like this. Yeah, so suddenly the mountains come close. Normally it's about 80 kilometers distance. Okay, so just to show you neuralgic facial pain. Here is another nice picture here. You see, again, the infraalveolar nerve. Here you see the fatty degeneration. And this is the answer for your question, or who asked this? FDOJ. Here you see a titanium implant, and directly adjacent to this implant is the fat. And this implant is stable inside the jawbone, okay? So every dentist would say, oh my God, be happy. This patient has a stable implant. And this patient can chew on this implant. Why are you taking out this implant? Yeah, because this patient has breast cancer, and this is consistently producing RANTES signaling. Yeah? And this is a ceramic implant, and here is also the fat. Yeah? So, cleaning out the fat and inserting an implant in the same session does not exclude each other. Okay, it's possible. So it's only one session. From the ultrasound we know, oh, here it's red. Yeah? So we open here a window, clean out the FDOJ, and then we insert the implant. And then we clean this with ozone, okay? We put in the PRF, of course, before we close with sutures and so on and so on. Yeah, and this is the misinformation. Yeah, everybody gets pictures like these. Yeah, is this a guarantee? Or are we always inserting implants in healthy jawbone like this? This is anyway not jawbone. This is what is it? Yeah, yeah. And here, are we sure? Yeah. And this is the connection we did in another research, the connection of local implant osteonecrosis and systemic osteoimmunology here. And the problem is how to assess this jawbone density on existing implants. Is it possible with X-ray? No. Everybody knows about the deviation, yeah, of the X-ray beams. This is the idea. This is from, well, we are good in connection. Professor Albrechtsson, you sure you know, in implantology, is a big guy in implantology in Sweden. He's from Sweden. This is the theory, wonderful. You see the cortical sheath around the implant. This is the foreign body reaction that holds the implant inside the jawbone, okay? It's a foreign body reaction. It's an osteoimmune reaction. It's not just a screw inside the wall. Huh? So this is the theory. This is looks like what you see. This is a lady with migraine, and this is what's coming out. This is the implant, and here you see the fat. And she's happy with the implant, but she's not happy with her consistent migraine. Taking out this implant, cleaning out the cleaning out the FDOJ, including taking out the implant, and she lost her migraine. She's happy now. And this is the question, the long-term immune sustainability of dental implants. How can we assess the long-term immune sustainability of dental implants? This is a paper we published 8 years ago or something here. Numbisi is a very nice guy in the United States, and Dr. von Baer is the owner of the IMD Berlin, which is doing all these RANTES analysis. Titanium implants and silent inflammation in jawbone, a critical interplay of dissolved titanium particles and cytokines, and RANTES on overall health. Here you get it on these QR codes. On this paper, we have up to now 62 assesses and 25 international citations. So it's it's of interest. It's not a weird idea. And this is coming out. We have 14 implants, titanium implants, removed, cleaned out the surrounding FDOJ here. And it's again the same boring panel, okay? The same pattern. Is it with breast cancer patients, or is it with MS patients, or here around titanium implants? Here the medium value of RANTES is always high here. And this is the reason why RANTES is nociceptive for facial pain. Here you have the synapses here, and here you have the gamma opioid receptors. And when you take morphine, then the gamma opioid receptors are activated, and activated gamma opioid receptors here diminish the nociceptive neurotransmission. Oh, sorry. But RANTES here desensitizes these opioid receptors here in the periphery sensory neurons. Let's say blocks them. You can say blocks them. Yeah, desensitizes them. And then here, the pain signals are transmitted in a higher intensity. And this is the reason why RANTES is provoking facial pain or neuralgia trigeminal. Trigeminal neuralgia. This is well known. This is not my idea. So the nociceptive reaction is modified and anti-pain response is blocked. This is another implant here, fatty-degenerative osteonecrosis here. And you could say RANTES is the fingerprint of chronic inflammation in jawbone. It's always RANTES. Excuse me, I'm dealing with RANTES now for 15 years now. I'm mostly fed up with the term RANTES. They introduce me on Congress and say, oh, now Mr. RANTES is coming. It's not my fault, you know. It's boring, yeah. And so RANTES here, yeah, RANTES-based diseases. Now let's go to Medline and PubMed. You know, Medline and PubMed is more stringent, more strict than Google Scholar. But RANTES and allergy, you get 1,000 articles. RANTES and neurodegeneration, 116, and so on. RANTES and tumors, you get 743 papers. Local osteonecrosis linked to systemic immune diseases. At the men's bathroom at the Wirra is this picture, sticker, flyer. Adaptability is in our nature. And this is basically what we want to emphasize. We want to increase your or the patient's adaptability. Having a great range of biological or immunological adaptability, we stay healthy. Yeah, we stay happy and healthy. No problem. Out of this booklet with 7 different diseases, so I took out those patients with rheumatic complaints. These are all patients with rheumatic complaints. We published this here. Chemokine RANTES as an unknown link between wound healing in the jawbone and systemic disease. Is prediction-tailored treatments at the horizon. Here, free download, and this is all in this one chapter of this booklet. Okay, you can order or buy this booklet. Robert Huber is doing this. So here it is. Now let's see what is coming up. Patient number 1, always the same thing. Here is the OPG. Here is what we are scraping out here. This is the drill. As you see the huge extent. Also here a little bony spongal part. Histology, again, myxoid degeneration. Myxoid, slimy. This is the consistency, this is the morphology here. And again, trophic disturbances. Case number 2 here looks like this. Opening looks like this. Here, some trabeculae, some spongal trabeculae from the bone marrow, and this is all surrounded with fat here. Again, vital irregular spongy bony tissue, medullary canal bone tissue, also here Knochen, bone from the medullary canal, here exclusively fatty tissue, medium-grade chronic inactive osteitis, low inflammatory, interstitial fibrosis, considerable fibrillary degeneration of the cytomesophyll of the adipocytes here, degenerated adipocytes. Again, trophic disturbances, hypoxic ischemic. Trophic disorder with regeneration phenomena, and so on. For foreign material, there is some foreign material inside. No, important, no evidence of inflammation. This is what I hate. We have a well-trained pathologist, but he has to write this. But I hate this. Why? In Germany, insurance companies, when the patient, to get his money, is approved as a medically necessary treatment, is showing the insurance company this pathohistological outprint, and they are reading no evidence of inflammation. They say, we will not pay this because Dr. Lechner did the surgery, was an unnecessary surgery because there was no inflammation. This is a wonderful example where you see what they are missing in their brain. Their main mindset is only on the side of acute inflammation, which is more an acute infection. We are not talking about infections, not about sepsis, yeah? and pus and swelling. And this is, we are talking about inflammation. Yeah? No ATP is good, no tumor, nothing. Yeah? We have, I showed you one patient where we had ATPs, where we had metastasizing cells of breast cancer. Yeah? Not in this case, just to show. Again, all rheumatic patients. And there are two patient groups where we love. These are the facial pain patients, because 90% of them, not 100%, 90% of them say, a few days later say, oh my God, my pain is gone. And second group where we have often sudden success or very early success are the rheumatic patients. Frozen shoulders, wonderful. The patient is coming 2 days later and the frozen shoulder is gone, really. Or joint problems, but always chronic ones, not acute ones, of course. Yeah. Tumor patients, of course. How should I evaluate the success? The patient goes back to his oncologist, okay? Or allergy things, for instance. Yeah. But rheumatic patients, wonderful. Again, pathology, fibrosis, fibrillar degenerative damage, fat cells, trophic fat cells, degenerated adipocytes here, trophic disturbance, no floric inflammation, no inflammation. These patients, these rheumatic patients, all don't know that they have these FDOJ areas at the jawbone. Again, and you see all these samples are different, and we have hundreds of these things here again. Necrobiotic changes here, fat tissue necrosis, no inflammation. And this pattern I showed you, the 7 cytokine panel from RANTES high, TNF-α and interleukin-6 low. This is a typical inflammatory pattern we only find in jawbone. All the rest of the body fat is different. Yeah. This means we dentists have the chance to occupy an absolutely unique situation in overall health, absolutely unique pathology. Yeah. Here I showed the RANTES. The RANTES 2,900 here, very high RANTES. All the rest, TNF-α, very low. Is in healthy jawbone it's 11, and in this pathology it's only 3.2. Interleukin-6 should be 100 in healthy, here only 4, you see. Totally missing interleukin-6 and TNF-α. Basically, this is the explanation why these patients have no pain. And basically, this is the explanation why these wounds here containing this fat never will cure by themselves. Okay? I'm working together with naturopaths, which are prescribing homeopathic remedies. Why not? I love homeopathy. But they think with one pill of calcium carbonicum X200, they can cure this FDOJ. This is not possible because the body itself is blocked on a biochemical level, on this cytokine level. This is the reason why the only way to cure it is to scrape it out and to clean it and to take care of proper wound healing. In case you have, well, FDOJ is of course a biological process. So what I show you here is the end state of FDOJ, of course. But we have a beginning, of course, and we have an ending, and this is the ending. And in the beginning phase, it might be that when you insert ozone gas here, it might be possibly you are able to stop this degenerative process. So it's not going up to this fatty degenerative end state, okay? But in general, only to install ozone treatment is not able to cure it. Definitely not. We know. Why do we know? Because we did it. We inserted ozone treatment. Funny thing, patient is getting a better feeling, okay? The shoulder is getting better, but the relapse is coming up 3 days later. It's not a definite cure. It's an asymptomatic treatment, more or less, but it's not a definite cure. And all these patients here, you see, this is a RICO, rheumatic inducing, or rheumatic arthritis, inducing cavitational osteonecrosis. RICO. But this is just joking now. Call it FDOJ. Again here, high RANTES in this fat. Again here, this is not the OPG, okay, this is a CBCT. Here, this is the canal. Should we clean this area or should we not from CBCT? Don't know, but CaviTAU ultrasound gives you the proper answer. Again, myxoid, fibrillar of myxoid degeneration, and so on. And now, because I'm collecting these pathological findings, I started 43 years ago. Now we have about 12,000 histopathological findings. Robert, I have to tell them. So I developed a machine, Another machine. Also we have 3 machines. CaviTAU. I have international patents. Second is Orotox. This is the patent of Professor Boyd Haley, not my patent. And 3 is also my patent. This is called MindLink. Mindlink.info. The question is, you have a breast cancer patient, okay? And this breast cancer patient, these are the teeth. She has positive CaviTAU here, 1819. She has positive CaviTAU 2829. She has positive CaviTAU in 3839 and in 4849. Rest of the teeth, perfect, okay? No root filling. Here is all green, CaviTAU green. I don't have green, okay, doesn't matter. Here is all green, and here is all green, and here is all red. Red. Now you know, CaviTAU is red. What does this mean? This means here we have, for 95% possibility, we have high RANTES expression, okay? From Google Scholar or from PubMed, you know, RANTES is connected to the development propelling of breast cancer. There's a lot of literature that when you block the RANTES receptor in breast cancer patients are cured. A lot of literature. So the question is, where to start? Which of these 4 jawbone areas, which of these 4 FDOJ areas is mainly connected to the patient's breast cancer? CaviTAU doesn't answer you that question, okay? Where to start? This is a question only the body itself can answer. And this is the aspect of kinesiology, okay? Kinesiology is the attempt to build up a dialogue with the inner knowledge, with the inner consciousness of the body, okay? Though with MindLink, we build up a connection to the inner knowledges of the body. Okay, so let's go on here with these rheumatic patients. Next one, and you see, again, you see here these oil cysts, you see here the fat here. Again, myxoid, fibrillar degeneration, and so on and so on and so on. These are just some of the papers, RANTES and rheumatic complaints. RANTES, chemokine expression in diseased and normal human tissues, or expression of the cytokine RANTES in human rheumatoid synovial fibroblasts. That means here, the synovias are chronically producing RANTES, not acute. Falling on your knee, it's extremely high. And now the question is, how can I make up the difference between a more or less acute inflammation in the jawbone and in the body, and our FDOJ in the jawbone? And the difference here goes via the serum. Okay. elevated RANTES levels in blood, in serum. RANTES has not yet gained any significant importance, since it's basically here there are more sensitive markers. Okay, so in traditional lab diagnosis, RANTES is not that famous. So we were able to demonstrate that in the fatty degenerative osteolysis and the surgical tissue, very high local RANTES levels were found in all the cases he examined. Not IL-6 is wrong. Very high local RANTES levels were measurable here, but in the local tissue here, TNF-α and interleukin-6 were not measurable. You know, I showed you. Now, so far it has been confirmed that elevated RANTES here, blood levels, are indicative of a local inflammatory process. This can be FDOJ, also RANTES CCL5 is a systemic inflammatory marker. But this is not specific for the FDOJ. Again, this pattern I showed you with high RANTES, okay? Columns, the column patterns with high RANTES. This is extremely specific for FDOJ. But high RANTES in serum is not specific for FDOJ. This is the problem. Yeah? Because when you have a chronic appendicitis, RANTES is high. No? Okay? So ideally, high RANTES levels in serum should be a sign of FDOJ, but this is not the case. Yeah. So again, additionally, when you in the beginning, I had the idea, oh my God, wonderful. We measure our breast cancer patients and they have high RANTES in serum. Okay? Next, we do the surgery. We scrape out the RANTES sources. Okay? And 3 days later, the RANTES level in serum is low. And this we do in 10 breast cancer patients, though we have the proof from our data that we cured the breast cancer. But this is an illusion. This is not true. Why is it not true? Because the wound healing itself is again an inflammatory process. So at least for 6 to 8 weeks, the serum in the RANTES is high because of the wound healing. Okay? Just later, the RANTES is going down. The RANTES level in serum is going down. Yeah. So RANTES in serum is a bit sneaky. Be careful. Yeah? Be careful. Now, how can we differentiate? Is the RANTES coming from the FDOJ or is the RANTES coming from another inflammation? And the point is, measure always RANTES and CRP. Okay? In case RANTES is high, like here, ELISA, not MELISA, ELISA, 44.6 should be below 30 nanograms. RANTES is high. Oh my God, it might be FDOJ. But looking at the CRP, and the CRP in this case is really low, so it is FDOJ. In case RANTES is high and CRP is low, then it's CRP is high, excuse me. RANTES is high, CRP is high. It's something else. It's your knee falling from the bike. Okay? CRP, always measure both. This is best. RANTES in serum and CRP. Basically very simple. So you are getting closer. And we have many doctors now understanding this. Yeah? You know, eye doctors, for instance, yeah? Having macular degeneration. Checking for RANTES. Yeah? RANTES high, CRP low, sending to a dentist with CaviTAU or sending to our clinic. These are all the patients we get from doctors. This is where we use here CaviTAU. This is the purpose of CaviTAU. Number one, this is the main reason, checking here the alveolar after extraction or wisdom tooth here. Radiology is mostly negative, but CaviTAU is in many cases positive. So wisdom teeth areas, this is just wonderful. Quite often, very often. In spite of local painlessness. We have the chronic inflammation, the FDOJ. We have the chronic overexpression of RANTES, CaviTAU positive, chronic overexpression of RANTES here. And at the end, the therapy will be a CaviTAU guided jawbone detox. This debridement of RANTES sources to set the jawbone free on this fatty degeneration, we love to call it jawbone detox. CaviTAU guided jawbone detox. Next one, implant in healthy jawbone. Question here. First, when you insert an implant, the question is the jawbone, you drill in, you insert the implant, is this healthy bone or not healthy bone? Okay? In case you feel, oh God, it's very soft, what is the answers of my oral surgeons? They say, okay, then I take a bigger implant. Is this true? Yeah, but they do. Yeah? Drill in, and then you realize, oh my God, I can't take it out with the fingers again because the jawbone is so soft, the area. Then I take a bigger one. I say, no, before you insert your implant, please check the bone quality with ultrasound. It's very simple, it's very easy. Chairside system. You have it by the chair. You check it. And in case it's red, you have the choice. Either to clean out the area, wait for 4 to 5 months, then check again with the CaviTAU, and when in case the CaviTAU is green then, before it was red, then you insert your implant. Or, you remember the picture I showed you before? You make a window on the side, not from the cranial rim, not from the crestal side. Take it out, and then you insert the implant, okay? And in case you leave your cortical rim crestally, the implant will hold. And now the implant has time, or the bone around the implant has time for the next 3 months to cure. Yeah. And then you have not the problem with the cases I showed you, where you have a wonderfully inserted implant, ceramic or titanium, doesn't matter, but the bone implant contact is a fatty degeneration. And with your implant, the patient is happy because he can bite and chew, or she can bite and chew. But you're damaging the immune system. You're destroying the immune sustainability. And I love the word of immune sustainability, because we all are talking about sustainability, environmental sustainability. Why? Because we understand when we chronically spoil our environment, this is not no sustainability. And at the end, we will pay for our regardlessness, because we throw everything away. This is the same. In case dentists don't care about the long-term immune sustainability of their patients, yeah, at the end, the patient will pay the bill, not here. And the dentist will say, okay, I will not care about the patient's prostate, about the patient's breast cancer or whatever it is, yeah, or multiple sclerosis. This is a change in system. This is a change in the mindset of our dental colleagues. This is what we try to achieve. It's making dentistry more difficult, but more sustainable. This is the difference. And then the next one is augmentation here. Yeah. Every dentist is grafting, doing the graftings, augmentation. But I don't know if I brought the case. There are many cases in the internet where the patients are complaining that implants are falling out of augmentations. It happened to me also years and years ago. And then I thought, my God, which dentist is able to decide properly, is the grafting he made or she made, is this grafting really a proper healing wound? Is this really a proper healing tissue which is able to hold the implants? And the X-ray will not show, but the CaviTAU might be positive here. Yeah. So the question is, and none of all these producers of allografts here are not able to say, is it better 3 months, 6 months, or 9 months? Nobody has really an answer on that. Yeah. One dentist says, I wait for 3 months, everything is fine, and others 9 months, but nobody knows. This is not science-based dentistry. And we also might have chronic inflammation inside augmentation. I can show you many patients, yeah, where we took out these augmentations, the grafting, and the grafting has high expression of RANTES. Yeah. Chronic overexpression of RANTES, and then you have eventually a CaviTAU-guided reconstruction of this grafting. And then the same use of CaviTAU in post-endodontic inflammation. This is a well-known term, post-endodontic inflammation, but nobody cares about this. Radiology is negative, CaviTAU is positive. Here it's pain-free, but you have a huge chronic inflammation around the apex. This is the reason why we in our clinic never ever do root fillings. Root fillings are nice because it keeps the patient's tooth. But root fillings are disastrous because they regularly are destroying the patient's immune system. And the toxicity is also destroying the patient's mitochondria. Yeah. So we have a CaviTAU guided extraction here of these root fillings, what we do. And we love to insert immediate implants, taking out the tooth, using the alveolar site, inserting the ceramic implant. Great, but you have to know, is the bone around the apex, is this inflamed or not inflamed? And here the CaviTAU gives you the decision. We make the CaviTAU before and we see, oh, it's huge. Here is the inflammation. So before you insert the implant, clean the bone or do it in 2 steps. Yeah? Wait, late implantation, not immediate implantation. And these are all these nice, wonderful, everyday uses of CaviTAU in a dental practice. The title is Reduction of Inflammatory RANTES Serum Levels by Surgery in Patients with Bone Marrow Defects of the Jawbone. This is basically, I was very glad, is a doctor in Luxembourg, these are dentists in Luxembourg, and I was just, this is Professor Müller, I was just one of the co-authors. And this is the problem I, 15 years ago, failed. It's not so easy to say, taking out RANTES here is immediately or automatically lowering the RANTES in serum. They tried, they did it, they had 113 patients. BMDJ here means bone marrow defects in jawbone. I love to write BMDJ hyphen FDOJ, okay? BMDJ, bone marrow defects in jawbone, is a terminology from mainstream dentistry. They know we have bone marrow defects. But the bone marrow defects we are talking about are these with these fatty structures, with this fatty degenerative morphology, okay? So they had 113 patients here. Serum concentrations of RANTES, CRP, and tumor necrosis were assessed, and so, and after, in the beginning. So. And this is one of the patients. All of these 113 patients were checked before the surgery with the CaviTAU. And here you see a patient with severely here in the right lower wisdom tooth area, also left wisdom tooth area. This might be a root filling here. And here also there might be FDOJ here. Funny, the left upper is not, is clean, okay? Here is just one of these 113 examples. And they checked these patients all, I don't know, 4 months or something like this later, and they checked them here. Are these FDOJ, BMDJ areas really gone, really properly cured, okay? And as they were properly cured, they have patients, they measure the serum concentration of RANTES here, no treatment control, had before this serum, you see 30, they should have made the threshold here, 30, you see, they were high, but no treatment here, even higher. With BMDJ or the FDOJ surgery, they were before, the RANTES contents went down dramatically here. Only tooth extraction, root fillings, before high, was also good, but was not so good as including additionally FDOJ surgery, okay? And root canal treatment of redoing the root canal treatment is also of benefit, was also of benefit, okay? So in case you have high RANTES in serum and you love to redo your root canals, why not? But then take the orotox and check the toxic level 4 months later, 5 months later, okay? And you will see that these toxins. Yeah. So here, no treatment, RANTES in serum goes up. BMDJ, FDOJ surgery, treatment, RANTES in serum is reduced. And all interventions together, it's also fine. So all you do on root fillings and on FDOJ areas is positive for the serum concentrations. So you help these patients' immune system quite a lot. This paper has now, this was published in September 23. And you see this paper has 1,746 views in 5 months. So it's also of interest here. Conclusion, BMD surgery, tooth extraction, and root canal treatment significantly reduce RANTES serum in BMDJ with surgery being most beneficial. This is the best one. Local aspect of root fillings. This is a root filling. One of my patients here. You see it's not sufficient here. Taking out the tooth. Why is this tooth black or dark red? These are the toxins. These are the toxins. And this means here, these bacteria here are invading the tubules here, the dentine tubules here. This is from a publication. This is not from us, this picture. Can we see toxins on the X-ray? Probably not. You need a chemical indicator to see toxins. Nobody can see toxins. Water here, water there, okay? But this is water, and this is Salzsäure, HCl, acid. Salzsäure is a German word. HCl. You know what I mean? Yeah. Both is same liquid. Could you see the toxins inside the HCl? No. You need an indicator. Yeah. But dentists say on the X-ray we can see there are no toxins. This is the official statement. I'm discussing with professors in Germany, and they are blaming us for diagnosing toxins here. These are all these volatile hydrogen, volatile sulfur compounds, H2S, and so on and so on and so on and so on. This is all inside. And one of these toxins has the wonderful name of cadaverine. Yeah, it's a dead organ, it's cadaver. It's cadaverine. This tooth here has the orotox value of 4. Orotox values mean 0 is totally clean. 1 is a little, 2, 3, 4, 5 is the maximum. So 4 is really high. We extracted this tooth, we opened this tooth, and what is inside here? Aspergillus niger, mold. Yeah. Funny enough, this patient is a butcher. And I said, look, in case one of your customers would open your sausage and the inside of your sausage would look like that, what will happen with you? He said, I will go to jail. All dentists leave these teeth, not going to jail. So this is an iceberg, you know, here. It's the same with the X-ray. Yeah? The X-ray is showing only the tip. This was below the surface. Below the radar is, you can't see. So orotox gives dentists and doctors a tool, mostly dentists, to find teeth which are the source of enzyme-blocking endodontically toxins. Why enzyme blocking? So short, this is the technique. You have a paper pin. You insert it into the sulcus. And the idea is that these toxins coming out from the dentine tubuli wander into the paper pin. And very simple. And then you get the vials with an indicator. You put the paper pin into this indicator here, and you wait for about 5 minutes. And then it's changing the color here. So dark yellow means high toxic concentration here, extreme. This is none, okay? So very simple. This is 1 minute, 1 minute. This is 5 minutes. So in 6 minutes, you can tell the patient, is this tooth a toxic danger for you? In 6 minutes, very simple. The only important thing is, you see, the periodontal socket here must not bleed. In case it's bleeding, you get blood into the paper pin, and then it's worthless, the outcome. Don't trust this outcome. So you have to treat, in case you have a bleeding periodontitis, you have to treat this bleeding first, wait for some weeks, yeah, and then do the orotox test. So clinical diagnosis, here this patient, chronic fatigue syndrome. And we presume all all patients with chronic fatigue syndrome have a problem in their ATP production inside the mitochondria. You remember the other case with the aspergillus in the jawbone, yeah? And so we measure routinely, we do this. We measure in patients with many root fillings like this lady and symptoms, severe symptoms, we measure the ATP here, IMD Berlin. We measure in serum, from blood, very simple, from blood, yeah. And we measure the reactivity on mercaptan thioether, okay? So ATP intracellular should be bigger than 1, only 0.65. That means, okay, this patient, it's no wonder that this patient has a chronic fatigue syndrome. Parallel to that, we measure the reactivity on this mercaptan thioether, but this is now an immunological finding, okay? It's not the toxic part. Volatile sulfur compounds are the toxic part of the endodontic problems. This is the immunological part of the endodontic treatment, because here we measure how the reactions on the patient's immune system on these toxins. So in Berlin, they measure interferon gamma or they measure interleukin 10. Why? This is two branches. Interferon gamma high means the root fillings are producing inflammatory reactions in the immune system. Interleukin 10 means it's blocking. It's connected to the Treg cells, because Treg cells are producing interleukin 10. So in this case, we know, it's inflammatory. Yeah, here, the immune stimulation. So we know, the toxic part is it's damaging the mitochondria. This is why we have low ATP, okay? The immunological part is stimulating interferon gamma. Yeah. Another case here, orotox. This tooth has orotox number 4, and this tooth has orotox number 2. In this case, it's different, you see. This case, these toxins are stimulating interleukin 10, are activating the Treg cells. Which traumatic immune disease has high activated Treg cells, has high interleukin 10 in the serum or in the immune system? This is cancer, okay? So you could say, in case this patient has cancer, what I don't know in the moment, I don't remember, you could say, oh my God, in case lady or man or whatever it is, dear patient, in case you have cancer, this high interleukin 10, this overactivated Treg cells might contribute to your cancer, might propel to your cancer. So, and here we have a root filling again, here. But of course, this inflammation here is also producing here the RANTES, is wandering over into the jawbone. So this is, we extracted 7 root fillings, and we cleaned the bone around the root fillings, okay? And we measured again the RANTES, or these 7 cytokine panel around the apices of the root fillings. And again, the same high RANTES, medium value here from 70th, low TNF-α, low interleukin 6, high interleukin 1 receptor antagonist. Always the same. It's boring. But it's the proof that root fillings, FDOJ, and the implants, they all have the same possible disastrous long-term effect on our immune system. So here we have one of these teeth here. You see the root filling. This is overfilling. Taking out. Here we refilled the soft bone, which we took out here. We refilled it with a contrast medium here. So you see the extent. You see this distance here from apex to infraalveolar nerve canal here is full of FDOJ. And in this bone, in this FDOJ area, we had RANTES 9,900. Dramatic. Patient has no pain on this tooth, but has breast cancer. Well, same here. Here. Again, the same thing, RANTES, only 1,500, but also breast cancer patient. But the sensitivity, the immune sensitivity on these dental toxins is really high in interleukin 10. Again, high RANTES producing cancer, toxins overstimulating Treg cells, overproducing interleukin 10, zack, cancer. You could say interleukin 10 is what? Is the handbrake for the immune system, okay? This is the same as if you would go with your car, handbrake on. Is this healthy for your car? Probably not. Well, so this is a case here. We took out these teeth. Here you see Orotox 5 plus 3, 4, dramatic here. Then taking out those things, inserting ceramic implants. So here, pre-post comparison of interferon gamma and interleukin 10. This patient here had interferon gamma high, very high, here, 62, here. And after the exchange of these root fillings with ceramic implants, it went down to 5.8. And here, interleukin 10 here went down to 0.1. Yeah. So this is a wonderful example how we stabilized this patient's immune system, yeah, just taking out these root fillings. This is another case, 3, 3, 3, 4. Here we made the implants here. So interferon gamma here was 3.7 with the root fillings. Maximum should be 0.3. Interleukin 10 was not sensitized here. And now, after taking out these 3 teeth, we have interferon gamma below 0.1 here. So, normalization. This is the X-ray. This is how the teeth look, okay? This is another patient. This is funny. Oh, there's another patient. So it's easy. It's easy. Yeah. But do the test first. I would not recommend to say, okay, we take out all root fillings, yeah, and so the patient is cured. Okay? Take the serum, send it to Berlin, have it checked for ATP. It's very important. And ATP is a real crucial item in oncology. No? They all say, no? Cancer is a problem of mitochondria, of a mitochondria disease. Again, looks nice, no problem. It's easy. Ah, yeah, and this patient here, I'm not an expert, his Rheuma factor quotient, I don't know exactly, was 19, and he had really severe problems here with these teeth. After exchange of these teeth with ceramic implants, it went down to below 9. Obviously 9 is the threshold. It's really low because the norm is 14. And his rheumatic problems here were gone. By the way, this paper is also published here. Okay. Ah, yeah. Sorry, mitochondrial function root fatigue. Yeah, this is a paper we published 2 or 3 years ago. Yeah, and I can recommend you that. This is very simple. We had, let's say, I don't remember, 10 patients. Each patient, or it were 15 patients, each patient we extracted a root filling, a tooth with root fillings, so like this. We put this root filling, this tooth, into a vial with aqua B-dest, okay? And left this root filling here in aqua B-dest for 24 hours. So very simple, leave it in there. Then this is what we call toxic solution, okay? Then we take part of this toxic solution after 24 hours, this tooth was inside here, and send this sample here to the lab, including the patient's blood, okay? With heparin, heparin serum, yeah, to the lab. And now the lab is able to measure the ATP delivery on the surface of the mitochondria. Then they add part of this toxic solution to the mitochondria and measure the activity after 24 hours again, okay? So the question is, what happens with the mitochondria when they are in contact for 24 hours with this solution? Okay, this is the question.
Blood you take before extraction or after?
No, we take the blood in the moment where we send to the lab at the same time part of this toxic solution and heparinized serum. Okay, same session. And then in the lab, this is the lab procedure they do in the lab. Okay, so very simple. Yeah. And then we get the results. Interestingly, this is the graphical abstract, but it's interestingly, this is the measurement of the ATP development on the mitochondria, okay? Each patient. We had, all these patients. And you see, most of these patients, this patient had a tumor, allergy, rheumatic diseases, allergy, neuralgic, so MS patient, and so on. These were all patients with severe diseases here. And the outcome is when the orotox is 0, okay, we have no change in the ATP energy after 24 hours, okay? When the orotox is high here, then we have, with this tox solution here after 24 hours, we have an ATP activity which was basically before we brought the mitochondria in contact with the toxic solution, okay, was 100%. And after a 24-hour contact of the mitochondria in the serum with the toxic solution, the ATP activity was only left for 49%. So let's go back. Only half of the mitochondrial activity of the original. That means leaving this root filling in this patient, okay, with tumor or allergy or rheumatic arthritis or MS, neurological problem, leaving this root filling in this aquabides only for 24 hours, okay, and then bringing this solution into connection with the mitochondria, okay, also only for 24 hours, okay, is reducing the mitochondria activity for 50%. But 2 objections. This patient had the root filling how long in the mouth? Not only 24 hours, for years. We have the root filling only for 24 hours in the water, okay? And second, and this was a problem for us in the beginning, when we took this toxic solution, root filling 24 hours, just as it is, and brought it into contact with the mitochondria, we could not measure the mitochondrial activity. Why? Because the mitochondria immediately died. So, funny, but interesting. Funny, but interesting. We had to dilute this toxic solution from 1 to 100. We had to dilute it 100-fold down. Otherwise, we couldn't measure the mitochondria. That means the toxic solution here is after 24 hours so toxic that mitochondria die unless we dilute it 1 to 100. Can you imagine that? But the dilution 1 to 100 is more or less the picture that, of course, the patient has also a dilution from these toxins, yeah, inside his tissue. It's wandering, yeah, the concentration is slowly going up. And we diluted also 1 to 1000 here. This is the dose. This is the orotox value. You see, all have high orotox values. This one not so high. Yeah. But at the end, we have this dramatic reduction in ATP in all these how many? 17, 18 cases here. Dramatic reduction in mitochondrial activity. Copy that. It's very simple. You just need a lab who is able to measure here the ATP activity on the mitochondrial membrane. This did my lab in Munich. Yeah. If you want to do it, refer to Wolfgang Meyer. He's the boss of the lab in Munich. You know, vitamin D, everybody is taking vitamin D. There is a lot of information that we all have low vitamin D levels and we should take vitamin D. Okay. I'm not an internal doctor. The question is a vitamin D supplementation in general in our FDOJ or in our implant patients, is this really a proper advice? That's the question, okay? In general. And so I would like to introduce you into some osteoimmunological properties of vitamin D. So it's very important that we have two sorts of cytokines in the bone healing, okay? We do a FDOJ surgery, and now we want a proper bone healing, okay? To help the patient for the rest of his lifetime, yeah, possibly. Now we have cytokines which are building up the bone, and we have cytokines which are destroying more or less the bone. That means we have osteoclastogenic cytokines here, and we have anti-osteoclastogenic cytokines. This is TNF-α, interleukin 17, and RANTES here. And we have here anti-osteoclastogenic, this is interleukin 10, interleukin 4, interferon gamma here. So we have a balance, okay? And best thing in biology always is to have a balance, yeah? Enough osteoclastogenic cytokines and enough anti-osteoclastogenic cytokines. So here we have the CD4 cell, and these are the cytokines we are interested in now here. Interleukin 10, interleukin 4, interferon gamma. They are enhancing the osteoclast activity, okay? And here we have the osteoblast activity, which is enhanced by TNF-α, interleukin 6 here. And you already know that what is low in FDOJ? TNF-α is very low, lower than in healthy jawbone. Interleukin 6 is low, below the threshold of healthy jawbone. So do we expect that in FDOJ the osteoblasts are active? No, because there is no induction of the osteoblast activity through these missing TNF-α and interleukin 6, okay? Another explanation why this panel, where I showed you in several diseases of these 7 cytokines here, we have no osteoblast activity, no self-cure, no self-healing in FDOJ. And then another interesting point is RANKL, the ligand. RANKL is also a ligand. CCL5 is also a ligand, RANTES, okay? Only a ligand here. And then we have TH17 and the interleukin 17 cytokines, okay. So this is control of bone cells by immune cells. This is the translation or interpretation or explanation of osteoimmunology. Bone cells and immune cells are connected here. Very important is the phase 1. Phase 1 means when we clean out an FDOJ area and we had done the debridement of the RANTES sources, and we want to cure this hole, this existing hole, we need an initial inflammation. And this initial inflammation should last for about 8 to 10 days. Normally, in a normal wound healing, this initial inflammation has to go back, is regulated down, a downshift. Yeah. Otherwise, if the downshift is not happening, we have a persistency of this initial inflammation. Okay? And then we get a bad wound healing. We also get a bad wound healing when this initial inflammation does not take place. That means for the wound healing after the FDOJ surgery or after inserting an implant, it's the same. Okay? We need an initial inflammation. We need high interferon gamma, we need high TNF-α. These cytokines, oh, sorry, I want to go back. These cytokines here are so-called Th1 cytokines. Here, TNF-α, interferon gamma, and so on. Th1 means inflammation. TNF-α is high, interferon gamma is high, interleukin 7 is high. And then we have the counterbalance of Th1. It's called Th2, very simple. And Th2 cytokines is interleukin 4, is mostly interleukin 10 produced by Treg cells. So, in case we have a shift from interferon gamma, this is low, and interleukin 4 is high, we have a so-called Th2 shift. That means this non-inflammatory side of this whip is down, is underexpressed, is underregulated. The other one, more the braking cytokines, are overexpressed. So this is more the gas pedal, the accelerator of your car, Th1, and Th2 is more the brake pedal. Okay? So we call this Th2 shift. Now, okay, Th1 is high here, and in all inflammatory diseases, that means in case it's above 21 nanograms, here this is high, and we always love to measure the Th1, Th2 ratio, and the ratio is bigger than 21. A ratio has no, sorry, has no nanograms or something, it's just a ratio. Here. And in case here, the other side, the ratio is low, we have a Th2 shift. So here we have a low ratio, here we have a high ratio. I show you. This is when we take the blood and send the blood to the lab in Berlin. Okay? We get this outcome checking Th1, Th2 ratio. So first we look at the Th1, Th2 ratio. In this patient, this ratio is 2.7. You can do this quite easily. Take the blood, send it to Berlin in 24 hours, okay? It costs about 110 or 140 euros about. So we see, and we do this with each patient before we touch him with implantation or FDOJ surgery. Yeah. Now in this patient, for instance, we have a ratio of 2.7, should be minimum 6.1 here. So that means this patient is Th1 underdeveloped, okay? Acute inflammation is blocked, chronic inflammation is high. No? Th1 is low, Th2 is high. Here. What, we don't look at the other ones now at the moment here. Just at the ratio. Very simple. Interestingly, you already get from the lab the information that this patient might suffer from chronic inflammations. Chronische entzündliche Erkrankung. Chronic inflammatory disease. Okay? This is very important because the lab is already telling you possibly this patient has an FDOJ from this ratio. Okay? This ratio is a crucial condition that the patient is developing FDOJ. So what happens in this patient when we do now a huge FDOJ surgery and when we expect that this cavity after our surgery is now curing properly and is developing an initial primary inflammation for 8 to 10 days. This is possibly, this immune system is possibly not able to do so because the Th1 level is pretty low. This patient has no TNF-α, has no interferon gamma available for this initial cure, which is essential and necessary. Okay? So be careful with this patient. Huh? Even this patient has a lot of FDOJs, be careful. The wound healing after your FDOJ surgery, the wound healing after taking out root fillings and inserting implants might be not so good. Okay? Be careful. So, you know, this is how FDOJ looks like. Low TNF-α, low interleukin-6. Okay? This is a research we did with 197 patients. These 197 patients here are divided in 7 different diseases. Okay? 30 had allergies, 56 had chronic fatigue syndromes, 57 have neuroinflammation, MS, ALS, 60 had rheumatic problems, 47 had trigeminal, 16 had tumors, and 46 had a so-called parasympathetic dysregulation. That means heart arrhythmia, high blood pressure, and so on. And this is the outcome. We made in these 197 patients, we checked this Th1, Th2 ratio. Interestingly, only 3 of these patients, only 3 of 197 patients had a high ratio. Only 3 had an inflammatory background of their disease. Okay, only 3. 27 only were in balance, and the rest had a Th2 shift. So that means 80% of these patients were all like this. Okay? Were all low in TNF-α, low in interleukin-6, yeah, were possibly not able to achieve this initial inflammation to cure the cavitations properly. Here. So the medium value of these 197, we say it different in German, patients, the medium value of the Th1, Th2 ratio was only 3.4 instead of minimum 6.1. Okay? And 74 of these patients had, additionally to the low Th1, Th2 ratio, they had extremely high Treg cell activation. That means the interleukin 10, the brake pedal, okay, was beyond 1,900. So you can say 80% of our patients, yeah, have such a blocked immune system that A, they must get relief from their chronic inflammations. But on the other hand, to cure these chronic inflammations is complicated because they are possibly not able to cure what you are doing. Problem. So this is the same. In FDOJ, we have basically the similar picture here. Th1, TNF-α is low, interleukin 6 is low, and the other ones are high. This is also out of balance. So FDOJ is nothing else than the mirror of the serum, of the overall immune system, okay, of a patient. Let's go back to 979 patients, 97 patients, with all these traumatic diseases. Here, again, TNF-α is low. The pro-inflammatory cytokines are too low, and the anti-inflammatory cytokines are much too high. So this is a problem, okay? But we say no problem, because we give all these patients a high vitamin D, high doses of vitamin D supplementation. Now let's think. What does immune biology know about vitamin D? Vitamin D is wonderful, okay? Vitamin D is able to enhance the differentiation of dendritic cells. This is very important in cancer, for instance. It's enhancing the B cell apoptosis here, so the antibody production is blocked. Yeah, wonderful, perfect in autoimmune diseases. Here, the antimicrobial peptides in macrophages are enhanced. Okay, it's wonderful. So what I'm saying, my critics about vitamin D, is only, please refer it to the FDOJ, okay? Because I'm not an oncologist, I'm not an autoimmunologist, that might be fine. But going to FDOJ here, what happens? Here, this vitamin D, in its inactive or in its active form, doesn't matter, here, is blocking, hemmen means blocking in German, okay, is blocking the Th1 level. Vitamin D is blocking the Th1 level. But the problem in all our patients is the low Th1 level. So this, instead of rebalancing this whip, vitamin D is here putting more weight on the Th1, so Th1 is going even further down instead of going up. Now, vitamin D is further means enhance, yeah, enhancing the Th2 level. Same problem, huh? Bringing Th1 down and Th2 up. So if vitamin D is not rebalancing this, it makes it, it makes it even worse. No, I lost my, here, sorry. It makes it even worse here. Treg cells producing interleukin 10, okay? More interleukin 10 with vitamin D. here, 30% of these 197 patients here have anyway Treg cells too high. So in these patients, the vitamin D will make the interleukin-10 expression, the Treg cells, even worse. It's just the opposite what we expect and what we need. And vitamin E, vitamin D here, is also blocking the Th17. Yeah. So you could say, when you have a patient in our clinic, one of these patients in our clinic, and you are doing FDOJ surgery, and you give them high doses of vitamin D, you are just producing the opposite effect what you expect and what you would like to do. So just thinking from this situation, from these research data we get from FDOJ, from these data we know about vitamin D. So this is possibly a problem. Now, again a problem. Vitamin D and the OPG rank system. OPG now here is not our X-ray, OPG. It's osteoprotegerin. It's an enzyme. Osteoprotegerin. Osteoprotegerin, very simple, is blocking the effect of RANTES. High RANTES is enhancing the activity of osteoclasts. Okay, it's diminishing bone. Yeah, it's reducing bone. Not osteoblasts. Osteoblasts are building up bone. Here, RANTES is going down. RANTES is bringing down the bone. And when RANTES is high in activity, at the end we would have lost all our bone. And then the body says, stop. Yeah? Too much RANTES is disbalancing our bone system. We are losing all the bone. So OPG, osteoprotection, bone protection, osteoprotegerin, is blocking the effect of RANTES. OPG, RANTES. Again a balance. It's again a whip. Very simple here. Now, here, RANTES is bringing up RANTES. This is obvious. We have high RANTES in FDOJ, okay? How is the bone condition in FDOJ? Very bad, because RANTES is producing or is activating RANTES. Yeah. Okay, RANTES high, RANTES from osteoblasts. Osteoprotegerin is protecting the bone. So at the end, our FDOJ areas probably would dissolve endless the bone, and at least we wouldn't have bone, jawbone left. This is not a good idea. Yeah. For instance, in rheumatic arthritis, the immune cells produce high RANTES, and high RANTES leads to the destruction of the joints in rheumatic arthritis. That's the problem of rheumatic arthritis. High RANTES, destruction of the joints. Now, here, osteoprotegerin is produced here to protect the bone. Now, OPG is inactivating here RANTES. This is the protection. Wonderful, wonderful. Here. That means OPG is hindering RANTES to destroy all our jawbone. So in case we block the RANTES here, So blocking the rancle through OPG, for instance, is diminishing the bone resorption, and blocking the rancle has the positive outcome that the bone density here in the spongial bone is increasing. So it's a good idea to block the rancle, okay, under the FDOJ aspect, because FDOJ has anyway high rancle because RANTES is producing rancle, okay? Now, here, the expression of OPG and rancle is dependent of many other factors. For instance, estrogens, okay? What are estrogens doing? Estrogens here are upgrading the OPG production. This is the reason why young women have no osteoporosis, okay? Because young women normally have high estrogen level. This is the reason why after the menopause, okay, estrogens going down, what happens? OPG is down and rancle is starting to damage the bone. And the end is osteopenia or osteoporosis. Okay? So estrogens here are great for the OPG production. Just an example. What are cortisones doing? You know, 20 years ago, people got cortisones for months. Sure you remember, now we are off that. What was the outcome when the patient took for months cortisone? The bone problems. Because cortisones block the OPG production in contrast to estrogens. Okay? Why? When the cortisones block the OPG production and the outcome is high rancle. What is vitamin D doing? Vitamin D is a hormone also, okay? Vitamin D is also enhancing and upgrading the rancle production. So what is vitamin D doing? Vitamin D has the same effect like cortisone. And so here, always be aware, giving vitamin D has the same effect on bone density like cortisone, or has the same effect here as women have after the menopause. And this is here endocrinology. This is not my idea. This is cited from endocrinology, blah, 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 blah. So, of course, you know who is familiar with the Coimbra protocol? Coimbra protocol? Coimbra protocol is they give MS patients with acute MS disease, they give high doses of vitamin D and they cure the MS patients. Why is this of great sense? Yeah, just one sentence, let me finish the sentence. Just because high vitamin D is bringing down the Th1 level, which is high in acute MS patients, Yeah. So it's a good idea when in all diseases where Th1 is high to give high doses of vitamin D. This is the Coimbra protocol. So here, this is a citation from symptoms of lack of vitamin D could be general exhaustion, muscle diseases, muscle pain, raised infections. This is right, because vitamin D is down-regulating the Th1 expression. For instance, when you have these pollens, allergy from pollens. Yeah, this is nice. Second dogma, in case the lack of vitamin D is for a longer time period, then it can end up in osteoporosis, which is enhancing the risk for bone fractures. This sentence is nonsense. This is not right, because vitamin D works in the bone like cortisone by enhancing, bringing up, upgrading RANTES expression, and so is producing more and more the diminishing of the bone by osteoclasts. Okay, it's finished now. So what is the alternative to vitamin D? It's melatonin. Melatonin is what we need for bone growth. And what we do in our clinic is, when we scrape out the FDOJ and we have these big cavitations, we take melatonin powder and bring it into the we guide the bone with melatonin. Then we add PRF, then we close the suture. Before we add melatonin, we take ozone gas, okay, and flood the wound with ozone gas, okay. You also can flood it additionally with procaine, also a good idea. Then we take melatonin, the powder, and then PRF, and then we close the suture. Perfect.
I have a question.
Okay.
A few weeks ago, I had a discussion with the doctor that it's already an end of the Guinness, and she had some thoughts about the hormones disbalance in the human body, yeah, like the estrogens, for example, that can affect the osteoblasts and osteoclasts normal, not to,
Oh, of course.
yeah, not good work of that cells, yeah, and also the fatty tissues, like forming the fatty tissues in the body, yeah. Did you notice that, for example, women are more attacked by this cavitations or
No. I would answer this question in two terms, okay? First, hormones and bone, yeah? You know, the first well-known hormone is vitamin D, but the more important one, in my opinion, is melatonin. Melatonin has a high impact on bone growth. It's very, very important, melatonin. This is number one. And answer number two is, of course, CCL5 is only the ligand, is only the messenger, okay? And the messenger, it depends where this messenger, in which organ the messenger is connecting to the CCR5, to the receptor, okay? But on each cell on the surface, you have a CCR5 receptor. And for instance, you have a CCR5 receptor on mast cells. So when you have a patient with mast cell hyperactivity syndrome, which is a new hype in medicine, yeah, this might be RANTES. RANTES is activating the receptor on the membrane of the mast cell. And the same is the receptor on your pituitary, okay? Pituitary or hypothalamus, yeah? Hypothalamus has many CCR5, also RANTES receptors. That might be chronic depression, or diseases connection to a hypothalamic disbalance, might also be connected to Jawbone, to FDOJ. Same hormone disbalances, because the pituitary also has CCR5 connections. This is in internet, when you check, you get a landscape for CCR5, for RANTES receptors. And it's impressive where overall in your organ is the receptor. And in case you are unlucky enough to activate the RANTES receptors in your neural sheath, you get multiple sclerosis. In case you are unhappy enough to activate this in your prostate or in your breast, you get prostate cancer or breast cancer. Okay? We have no pattern now or template why it's going in this case there and in this case there. This is of course dependent on DNA signaling. This is probably dependent on our lifestyle, and this might be also dependent on our attitude, on our ethic attitude, spiritual attitude. And this is called epigenetics. Okay? This is a wonderful word to close the first part, epigenetics. This is too much.
And how do you measure it?
Yeah. Robert, how do we measure the volatile sulfur compounds? We didn't bring literature on that, but if you remember Orotox, we have indicators, and the indicator, the system is called Orotox. Orotox. And if you go to orotox.com, bitte? DE? Oh, thank you. DE for Deutschland, DE, orotox.de.
I'm just happy that we are using this one, and I'm doing this for our patients, and it works indeed.
Thank you, thank you, thank you. You get them. Yeah, you get it, the Orotox. Yeah. Just go to the website, okay? It's very interesting. Very simple and very interesting. It was developed, not by me, it was developed by my friend, Professor Boyd Haley. Professor Boyd Haley was a chemist at Kentucky University, and his daughter was nearly dying when she was 20, 25. And then a holistic doctor in the US took out all her root fillings, the teeth, and she was cured immediately. And so Professor Boyd Haley, as a scientist, of course, was thinking, why don't dentists know that root fillings might be a danger for the overall health? And so he developed this indicator, volatile sulfur compound indicator, because these are sulfur compounds which are coming out. Who is producing the sulfur compounds inside the root filling? The bugs, the bacteria. Of course, the remaining ones. It's an illusion of all these endodontists that they are 100% able to clean out all bugs. So 4 weeks, 6 months later, the bugs are, the population of the bugs is growing up, and the bugs are digesting amino acids. And what is coming out? Like in our body, an outgas, which is toxic volatile sulfur compounds. Sulfur, hydrogen, and so on and so on and so on. And with this indicator, we can make these toxic compounds visible. Very simple. It's not harmful, easy, simple. Go to Orotox, I can recommend this.
Like a Melissa test?
It's similar to the Melissa test. The Melissa test was developed by my old friend Vera Staskal in Sweden, in Stockholm. 30 years ago, I visited her, and it's a bit different. My friends, my immune friends, are a bit criticizing Melissa. It's too sensitive. It's hyper. It's too much. Okay. But you also can use Melissa because Vera Staskal 30 years ago already was against titanium due to her Melissa test. Do you know the name Vera Staskal? Yeah, you know. She's originally was from Czechoslovakia. I knew her very well, and I know her daughter, which is continuing the Melissa thing now. But we have better immunological labs now in Munich. Although Vera Staskal was the first one.
Is it possible to have FDOJ around ceramic implant?
FDOJ around the ceramic implant? Good question. I will show you. Yes. Ceramic implant is not a guarantee that you have an FDOJ around the implant. Titanium is even worse, but ceramic is not 100% excuse. And these are the crowns. Looks nice. Okay, this is everyday work. Okay, question?
A small comment. I remember that you told that the first idea was not just for the dental bone quality to check with this CaviTAU device, but also for the early stage of the fingers. For what disease or what?
Yeah, the thing is, pediatrists, they, in case boys, mostly boys, are not growing properly. They are too small. And they can see it on the joint, on the finger joints. But I'm not an expert about this. This is just an idea from one of our doctors to use it for this purpose. But this is not what we propagate because I can't tell. I have no idea about this. Okay, questions? Just to show you two impressive cases, where our patients were really happy with the diagnosis and with the treatment. Okay.
Can you repeat your answer about should we check for FDOJ if patients have all vital teeth and no extracted?
Oh, this is what we normally do not. In case the OPG is nice, we make the ultrasound only on these areas where we have suspicion. Suspicion is old extraction sites, especially wisdom tooth areas. Suspicion is below root fillings, very important. Suspicion is around implants. These are the most important points. You have chronic facial pain patients. Sure. Yeah. And normally what do they get? They get psychiatric remedies. Yeah? Pardon?
Neurosurgeries.
Or neurosurgery. Also, I didn't bring these statistics. Yeah, we have many patients with Janetta surgery. Yeah, and the Janetta surgery, works, but it works only for 6 months, and then the pain comes back. So our question is, why not going immediately at first to the periphery before we go central? No? This is a
Can you predict the result with protein test in such a way?
yeah. Here in neuralgic cases, in facial pain cases, you get a success rate of 90%. It depends on the time.
And if you check with protein test, let's say to prognose the result.
You can do this. You can do this. This is the procaine test. Yeah. In case it's positive, it's okay. You know what to do. But in case it's negative, yeah, the procaine might not be strong enough to change the situation. Yeah. So we left it. Yeah. My friends in the US.
You're not making protein test.
Pardon?
Well, you are not making protein test.
No. We make the ultrasound. Much easier. And then we know what to do. Yeah.
Excuse me, this girl which you showed, she had the extraction of wisdom tooth. Some
Husband certainly once toyed with the idea of taking his own life.
Sorry. Yes, of course. Of course. Yeah, yeah. Yeah, yeah. And this is the preliminary areas, the wisdom tooth areas. Yeah. Because I think our mistake is to take out total anesthesia, yeah, to take out all 4 wisdom teeth in one session. This is fine, yeah, because we tell the patient, oh, this is just one session, yeah. So for 1 week you are swollen or you get antibiotics and then it's gone. And this is not true. By this we create these FDOJ areas in the wisdom tooth areas.
oh,
Yeah, this is really a bad idea. We recommend to do it one after the other. Yeah. Because our immune system is not really able to compensate it, to cure these wounds. These are the facial pain patients, because 90% of them, not 100%, 90% of them say a few days later, say, oh my God, my pain is gone.
90%.
Pardon?
90?
90%. About. Sometimes it takes 2 days, sometimes it takes 2 months. Okay? Pardon?
For how long?
After the surgery.
About after 1 year, after 2 years.
Now, yeah. The problem is we have about 20% of the patients which have a relapse. This is the question for proper wound healing. Yeah. In spite of all these means we're taking later, yeah, infusions and PRF and ozone and whatever, we have relapse in wound healing. Yeah. And this is the reason why also we have a relapse in symptomatic problems, facial pain and so on.
and can I ask you, you have this ultrasound 3 years and you do this 40 years. How before this ultrasound you diagnosed to do this?
Yeah, it's a good question. It's a good question. Honestly, for nearly 3 years we have the own machine. Honestly, there was an American procedure. It was called CaviTAU, and I had 2 of these CaviTAU machines 20 years ago. We started with the CaviTAU. The CaviTAU is just off the market, and now we decided to build a new one, to develop a new one. Let's say 20 years ago. Now modern technology is further. We have a better machine. We have better technology. And the idea is the old CaviTAU had the problem, the sender and the outside sender and the in-order receiver were disconnected. So this machine had the FDA approval, but they said it's in the FDA approval they consisted that it's user dependent. And the machine which is user dependent, it's a problem to get objectified data. So I said we need something, yeah, where you always have this parallel situation, so you get objective data. Yeah. This is very important. This is different from the old CaviTAU to the new one. But this is a good question. And 20 years before, we did not know that RANTES is inside, okay? But I did one of these bioenergetic tests, you know, electroacupuncture. Electroacupuncture. This was an old German doctor, Dr. Voll. I knew him, or I saw him once, let's say. I saw him before he died. Electroacupuncture is nice, but it's very complicated to learn. You measure, exactly, you measure the voltage in the meridians, inside the meridians. And it is a wonderful machine. It's a wonderful technique, but it needs a lot of exercise and it needs a lot of expertise to get really good outcome. Yeah. So I think you young doctors, you don't have the time to do this. It took me 45 years ago, about 1 year of exercise. We did it on these acupuncture points on the fingers, here and there and here and there. And well, it was a time where all my friends, when they met me, were hiding their fingers deeply in their pockets because I said, come on, I want to measure your meridian. And they all were afraid of the painful measurement. Yeah. When you are an expert.
Have you tried the kinesiology test?
Yes, yes. Applied kinesiology is the one. We are changing to a certain system. And well, it's an extra seminar again. We are changing to not this muscle test. We are changing to a tendon test. It's called the arm length test, or the O-ring test. Yeah, it's also possible. But the arm length test is very simple and very easy. Yeah.
The last question from me.
No, it's not, because
if you make thermography, how you see this? It's like a hot place, cold place, just with thermography, this degeneration.
This is a problem. I know all these guys from thermography. This is an old problem, because when you have a parodontitis, it's red. Yeah. Very simple. Basically, it's a cold place. Yeah. From its energetic situation. Yeah. It's not inflammation.
Low voltage.
It's low. Yeah. It's low. Yeah. It should not come up red. Yeah. It should come up and but this is a great discussion. Yeah. This is why I left, or I didn't start with thermography in my clinic.
But CRP must be lower than the norm or in normal range?
No, yeah, in this case, yeah, the lower CRP is, or
Normal range was
yeah, below yeah, normal range. Normal range, not high, not above 3. CRP is 3 is the border, yeah, not above 3, let's say. Yeah. So always check. Yeah. It would be great if you would have a very specific indicator in serum for FDOJ. I'm sorry, the body is disappointing us.
Can I ask you?
Yes, please.
When you extract root-treated tooth, how deep you clean the bone?
Yeah, you, in case it's not too much, yeah, and you want to do an immediate in one session, yeah, take the burr, take the drill, yeah, and clean the bone. and you feel when the spongial bone is soft. You can feel that. Yeah, trust your fingers, trust your sensitivity. Yeah, clean it, clean it, and it's amazing how big, in spite of total radiological inconspicuously, how deep and how far these things can be. But to know is wonderful when you see the CaviTAU. Yeah, you know it's highly red, or it's just a little. Yeah.
And what about osteoporosis and CaviTAU?
Well, osteoporosis in the jawbone, we have this fatty degeneration. But osteoporosis is a total different process than FDOJ.
Yes, but if you do the osteoporotic bone, there's less bone in volume inside. So your device should also provide the data that it's more red.
No. In osteoporosis, you just have a diminished bone density because of lack of minerals. But here we have this RANTES-driven inflammation. You never find RANTES in an osteoporotic bone. There is no RANTES. It's a totally different process.
But your device is also it shows if there is more density, so there will be green, and if there is less bone.
Yeah. Again, I'm saying we measure with the CaviTAU the density of the bone, okay? But this is not 100% true. We measure the attenuation, okay, of liquid. And we measure the attenuation of a specific liquid. We measure the attenuation of a liquid which is expressing RANTES. This is the difference between the soft FDOJ and the soft cheek. The soft cheek is green, okay? Just telling you, because in case you get the CaviTAU and you never heard me talking about the cheek, and you get the idea to hold this very simple on your cheek and it's green, you are totally confused. We were also totally confused when we developed CaviTAU, okay? We were proud to develop this, and wonderful. And one day I came to the idea, let's measure the cheek. And the cheek was green. It was a big confusion, yeah, in our development. Yeah. But the answer is we are measuring the attenuation. Yeah. Basically not the bone density. So the Robert, wie heißen die Dinger? Wie heißen das Scaling bei der Osteoporose? Der T-Scan heißt es, gell? So, when you measure osteoporosis, when you are an elderly lady and you go to the orthopedist, and he says, it's very simple, we have a machine and measure the osteoporosis here on your arm. This machine is ultrasound, and the measure is so-called T-scan. Huh? You hold in, here you have a sender, here you have a receptor. Yeah? There are many of these ultrasound machines on the market, and they measure the T-scan. Yeah. A T-scan. They measure also the bone density. They measure not the attenuation of the liquid inside. Okay? So the idea to have a sender and a receiver in a parallel application is not new. But it's absolutely new to have it orally and to have it in a device which you can use orally. This is a difference. I know this because many of my patients had the problems that on I think it was in Japan mostly, where they said, oh, all these appliances also already exist here. Yeah. So the idea is not new, but the idea is new and orally, and we measure different things than in osteoporosis. I hope to answer your question. Always be aware it's two completely different procedures inside the bone, FDOJ and osteoporosis. Yeah, totally different. FDOJ is totally independent from the hormonal situation, okay? I told you from one of these soccer players in Munich, yeah, 25 years old, totally healthy, yeah, definitely no hormonal problems. No? He had no osteoporosis. He had the FDOJ. And he suffered from RANTES expression. RANTES was the connection to his central nervous disturbance, to his vertigo. And the vertigo was gone the next day. So they took him back to Dubai. Yeah. Okay? It's not easy, it's sometimes a bit complicated. Yeah.
And is it possible to get the rule in?
Yes, 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 we have. The question is just, okay, the question is how long? Because, I said it in the morning, you have bacteria inside remaining. Just one couple, okay? They have sex, yeah? They have children, okay? And it's building up a population, a big population. Nice children, wonderful, yeah? More and more toxins, yeah? Because they are eating up the amino acids.
And this interleukin-10 we can also make from blood serum.
Yes. Good question. This is from the bone, from the jawbone, below the root filling here, okay? And this is from the serum. So this is a bit more complicated. If you want to follow my research with IMD Berlin, okay? Take this sample, you scrape out, okay? Very simple. Put it into a vial. First call IMD Berlin, okay? Call IMD Berlin, says, you heard Dr. Lechner's talk, and you also want to measure RANTES in jawbone. Then they send you these vials, no problem, okay? So you put this sample, FDOJ sample, into the vial, and now it's important. Store this sample in the fridge, freeze it down, because RANTES is volatile, okay? So freeze it down. And optimum, have it sent frozen to Berlin. DHL is doing that. Frozen, then you have time, okay? No, it's 80 euros. It's 80 euros per sample. And when you mean the transport, at least in Germany, they do this. Yeah, ask them, tell them. When you collect 10 of these samples, FDOJ samples, and you send them 10 of these samples, that means from 10 of your patients, yeah, then they pay for the transport. Berlin, they're very generous. Yeah, they pay for the transport. Yeah. You can collect them, store them in the fridge, yeah, deep frozen, yeah, for months, for weeks, for months, for days. Yeah, you have time then, okay? It's not necessary to send these samples to Berlin in 24 hours. The blood samples, the serum samples, must be there in 24 hours. Otherwise, the results are distorted. Okay?
What temperature must be?
Oh, take the fridge, freeze it down in the deep freeze. Yeah, doesn't matter. Yeah. This is not so important. Yeah. Just prevent it from being volatile. Yeah. Gassing off. Yeah. Pardon?
Must be thermopack.
A thermopack? No. We just put it in a simple box. Inside the fridge, you mean? No. The thermopack, they deliver for the transport. But you don't need the thermopack.
What is aquabidest?
Aquabidest, double sterilized. No? Aquabidest, double. Aquabidest. Yeah, I'm sure you use aquabidest in your clinic.
Distilled water?
Yeah, distilled. Simple or double distilled water. Yeah.
What's your mind about why the body doesn't remove such a toxic teeth?
Oh, this is a good question. You know, from its inner wisdom, yeah, from its inner knowledge. Now, teeth are strong inside the alveolar bone. You know, extracting teeth.
It's a very acute inflammation. It could erupt it or
Yeah, when you have an apical inflammation, then the tooth comes out. Then the patient says, "Ouch!" Yeah, when I bite, I get a pain. But this is the acute infection, okay? But the chronic, yeah, you know, I mean, my answer would be, the problem in medicine, in modern medicine, is that we have a perfect medicine. Everything which is connected to acute diseases, okay? Breaking your leg, I love to ski, I'm 75, but I'm still a keen skier, yeah? I never broke my leg, God thanks. But breaking your leg, yeah, they do wonders. They are wonderful, yeah? Or having an acute inflammation, yeah? This is no problem. But the problem in medicine is the chronic thing, yeah? Alzheimer's disease, yeah? Cancer. There is no progress in cancer, statistically. We spend billions, and there's not real great process. Well, lymphatic cancers is better. Children leukemia, children leukemia is good to treat, but many other problems still remain dramatically. That's the problem. And one clue, just one clue, are these chronic toxins from root fillings, are these chronic low-level inflammations in FDOJ. Yeah. And in RANTES, in FDOJ, we know it's RANTES, and here we know it's these sulfur compounds. Yeah. These sulfur compounds, these sulfur compounds are so toxic, yeah, that here this water is, we call it toxic solution, is ruining directly the mitochondria, it's killing the mitochondria. And for Wolfgang Meyer and me, in the beginning, this was a huge problem. Because he said it doesn't work. What are you sending me? I say, no, just aquabidest. I send you aquabidest. With 24 hours inside of a root filling. That's all.
Probably nothing will happen.
I didn't try. I didn't try, but why not? You know, it's not making an acute digestive problem. You can drink that. Yeah. Yeah, of course. Yeah. But it's good because it's not acute. No, just to make the to differentiate between acute and chronic. Yeah.
So the conclusion: the man is very powerful.
Pardon that?
The man is very powerful if we have inside in our mouth such a big toxins,
Yes.
we are still alive.
Yeah. You remember the picture I showed you from the bathroom? Adaptability. We have a huge range of adaptability, God thinks. This is nature. And it depends on your DNA and it depends on your lifestyle. But when it's at the end, the symptoms come up. And all these patients we have are at the end of their adaptability, because otherwise they wouldn't be in our clinic. They would happily dance around in the disco. And this is what they aren't doing.
But healing is more physics. We are all study chemistry, but healing is it is electron donor or stealer tissue. So you can use biomodulators and insert electrons here and don't look to chemistry.
Yeah, this is of course is a good idea. This patient needs a magnetic field probably after the surgery. Yeah.
So we're using it very, very successful.
Yes, of course. This is, we do a lot of these magnetic things, and LED lights and whatever. Yeah, it's a good idea. Yeah. Just talking about the problems now. Yeah. Your question?
So it's like it works like immunosuppression.
Pardon? It was like
It works like immunosuppression.
immune suppression, of course. When you want to bring down the immune and a dysregulated immune system, give vitamin D. But in all chronic patients, like we have in our clinic, it doesn't make much sense, because we want to bring up the Th1 level.